भैया अभी थोड़ी देर सेटअप करो अभी।
Disease outbreaks.
Check this 1 2. Hello, check this. This 1 2. Hello, hello.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
Hello.
Santavattan de Purani like Kitani was so Santa Pudan. Me Saban Sara Kadite and Kevastan Santa, Santa Chivaita.
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water.
अब आवाज आ रही है?
मेरा मेन आ रहा
Villages in the communities with limited access, thus empowering marginalized communities.
महिलाएं आती हैं उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है। और
and affordability of health services are the key deciders for accessing healthcare. The Heart Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CHC रहेगी वही बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहां तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में हमारी वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as Ashas or community level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते हो तो बाजार में जाने से क्लिनिक खुला है, वहाँ जाके चेकअप कराइए, सब बोलते हैं।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
मेरे को परेशान बहुत ये घुटना महसूस था, ये पैर महसूस था, ये पूरा शरीर मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोल को, अभी सबसे और दवाई मन लेता अभी तो रती था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Pasar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible. Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision of that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint gap mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remain unheard in government's decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
ये यहाँ रख दो ना, ये यहाँ लगा दो ना, यूं करके चाहे ऐसे ठीक है। क्या अब अरे अभी तो मुंह पे हाँ ठीक तो है, अभी तो गया मार्केट। आपको देख लो, यहाँ से देख लो, वहां से समझ नोट से नहीं सकता।
संत वस्तान देव पूरा लीला सिंह पिता निवास भोग संत सुधा नीचा बन सारो का देव पीते उनके वस्तान संता सब संत शिवाय संत
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव से आए सयान सजनमन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें।
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है, जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं
Good morning. Good morning, ladies and gentlemen. A very good morning to you on day 2 of our conference.
Please take your seats. Please come to the round tables and have your seats. We will be beginning our session for day 2 shortly. Good morning, Namaskar. Your Excellencies, distinguished delegates, honorable participants, colleagues, welcome to the second day of the Global Conference on Digital Health organized by the World Health Organization's Regional Office and the Ministry of Health and Family Welfare, Government of India. Yesterday, it was observed that this is not just merely a conference, but it is a roadmap to charting the future of digital health. And we look forward to more transformational discussions on the day two today. Thank you very much, ladies and gentlemen, for being here. In keeping with its fundamental philosophy of Sarve Santu Niramay, or well-being for all, the Government of India tabled and shepherded the first ever resolution on digital health at the 71st World Health Assembly. More than half of WHO's member states, as we have observed yesterday, have since developed digital health roadmaps as well as costed digital health plans. Likewise, the regional director of WHO for Southeast Asia, Dr. Poonam Khetrapal Singh, very early in her tenure in her high office, enumerated UHC as a fundamental edifice to build the regional health strategy, the regional health architecture, and incorporated universal health coverage as one of her 7 and then 8 flagship priority programs. If UHC, ladies and gentlemen, is the cornerstone of health for all, then digital health ensures that we can leapfrog to that goal with better availability, accessibility, and affordability for the health and well-being of billions. On that note, we look forward and proceed with these discussions on the second day. Ladies and gentlemen, it is my great honor and pleasure, singular pleasure, to welcome on stage His Excellency Dr. Mansukh Mandavia, Honorable Union Minister for Health and Family Welfare and Chemicals and Fertilizers. Your Excellency, please. Dr. Mansukh Mandavia, Union Health Minister, India. Ladies and gentlemen, it is now my singular pleasure to welcome His Excellency, Mr. Joe Bijang, Honorable Minister of Health and Human Services, Republic of the Marshall Islands. Your Excellency, please. Ladies and gentlemen, Mr. Joe Bijang, Health Minister of the Republic of the Marshall Islands. It is now my honor and privilege to welcome Dr. Poonam Khetrapal Singh, the Honorable Regional Director, WHO Southeast Asia. Dr. Poonam Singh, please. Madam Regional Director. May we please welcome our distinguished delegates from the countries in the order of the English alphabet. From Denmark, Mrs. Nina Bergstad, Senior Advisor, Office for Data Infrastructure and Cybersecurity, Ministry of the Interior and Health, Denmark. From Mozambique, Mrs. Bernardina de Souza, National Deputy Director for Health Training, Ministry of Health, Mozambique. Mr. Bader Avlathani, Director General of Information Technology from the Sultanate of Oman. Dr. Preetha Rajaraman, Health Attaché and Regional Representative, Department of Health and Human Services of the Secretary of the for Global Affairs, Embassy of the United States in India. And the representative from the European Union, the European Union's delegation in India, Dr. Benoit Savaroche. Ladies and gentlemen, allow me to welcome the moderator for this high-level plenary session. This high-level plenary, Dr. Prem Namgyal, Director for Program Management, WHO Regional Office. For more discussions on critical transformational milestones in digital health, ladies and gentlemen, I have the pleasure in handing you over to Dr. Namgyal to moderate this high-level plenary. Thank you, ladies and gentlemen.
Thank you, Gautam. Your Excellencies, distinguished delegates, ladies and gentlemen. It is my pleasure this morning to moderate this extremely important high-level plenary session of this two-day meeting on digital health. The MC has already introduced all the distinguished speakers for this high-level plenary session, and I will straight away jump into requesting the distinguished speakers. First of all, Dr. Mansukh Mandavia, the Honorable Union Minister of Health and Family Welfare and Minister of Chemicals, Fertilizer, Ministry of Health and Family Welfare, Government of India. Your Excellency, yesterday we were fortunate to hear your opening address where you highlighted many of the notable achievements that India has made in such a short time frame, which not only benefited India, but also many countries beyond the borders of India. Today, we are doubly pleased and fortunate to have Your Excellency with us physically, despite your very busy schedule to be here with us. And I would like to request Your Excellency to give your thoughts in your keynote address to this plenary session this morning. Therefore, Your Excellency, once again, thank you very much for being with us, and over to you, Your Excellency.
Yeah. Good morning, everyone. Sitting on dais, dignitaries, ladies and gentlemen. It gives me immense pleasure to be here with distinguished guests on the second day of Global Conference on Digital Health, which has provided a global platform for enhanced cooperation and technology-driven solutions in health sector aimed at taking universal health coverage to the last mile. Digital health interventions are not just limited to individual healthcare delivery programs, but are spread across multiple health outcomes, catering to both communicable and non-communicable disease across the health and disease burden spectrum. India has taken a quantum leap towards leveraging digital health solutions for effective health service delivery. I would like to highlight a few achievements of the country in the digital health and service delivery domain, which showcase India's capacity to scale technological advancements for a country of 1.35 billion people. In the maternal and child health domain, India has created name-based database of 200 plus million eligible couples, 140 million pregnant women, and 120 million children who are being monitored for antenatal, postnatal, and immunization-related health services. Another key example is the Nikshay intervention under the National TB Elimination Program, through which more than 11 million patients are tracked for adherence to TB treatment. India's focus on comprehensive primary health care is underlined with the NCD application through which more than 15 million population with 30 plus age has been screened. For 5 NCDs, in turn creating a health profile for India. Using integrated health information platform, which was developed in collaboration with the World Health Organization as a national surveillance system, we have ensured name-based GIS-enabled near real-time surveillance of 36 epidemic-prone diseases. E-Raktakosh, all the blood banks across the country, and online reservation systems application provides online appointment for government facilities across the country. And Mera Aspatal for giving feedback on health services provided by the hospital. Other well-known pan-India applications included e-Sanjeevani and COVID. E-Sanjeevani was largest telemedicine network, ensure free of cost online telemedicines, video calls to citizens. So far, more than 100 million teleconsultations have been conducted through this platform. The globally renowned COVID vaccine management platform has supported administration of more than 2.2 billion COVID-19 vaccine doses. Friends, yesterday, I have touched upon the 4 pillars on Ayushman Bharat, the Long Live India mission. Today, I would like to opportunity to delve deeper on the digital aspect of the Ayushman Bharat digital mission, which is cutting across all domains for enablement of digital health ecosystem in the country. Under ABDM, the government has initiated creation of registry for patients in the form of unique patients' IDs, health provider registers, and health facility registers as an essential foundation for any health programs to be interoperable with other programs. More than 332 million unique patients' IDs, more than 200,000 health facility registers, and more than 144,000 health professional registries have been created so far under ABDM. Taking forward, the government's focus of breaking the silos ABDM will lead to the creation of longitudinal health record of patients, which can have been burning of continuum of care across primary, secondary, and tertiary levels of care. ABDM also enables newer technologies and advanced data analytics to be integrated with existing solutions aimed at avoiding repeated diagnostics, accurate diagnosis, precision medicines, increased quality of care, timely response in emergencies, and lowering out-of-pocket expenses. While India is already working toward creating an enabling ecosystem for digital health, in country. Through various policy level reforms, implementation and scaling up of this digital intervention is parallelly focused often. Friends, even though we have utilized multiple technological intervention in health, we have still leveraged only the tip of the iceberg. Digital transformation requires multi-pronged efforts with special emphasis on leveraging cutting-edge technologies such as artificial intelligence, machine learning, and both logic and AI-based clinical decision support system to achieve the overall vision of digital health ecosystem. Indian government has taken ambitious steps towards convergence of advanced technologies in the delivery of healthcare services in the country. Premier tertiary care institutions of the country like AIIMS Delhi, AIIMS Rishikesh, and PGI Chandigarh have been designated as the Center of Excellence for Artificial Intelligence in Healthcare, with an aim to enhance adoption and promotion of health data standards. The Center of Development of Advanced Computing, Pune, has been designed as the National Resource Center for AHR standards to achieve synergy between siloed and vertical national health program. A National Public Health Observatory has now been established at Union Health Ministry level, with nodes at state and district level, which will yield the twin benefit of effective public health monitoring and health emergency management. Based on our learnings, I would like to highlight the 3 policy enablers which every government should prioritize. First would be digital architectural frameworks for a country for establishing a digital ecosystem. Secondly, government should ensure standardizations of data, focus on data security, privacy issues. Third, integration of multiple applications for data-driven policy making should be major focus globally. Government of India believes that digital tools have immense potential and can play a critical role in strengthening and transforming healthcare delivery system. At this juncture, it is crucial to converge our efforts toward building a culture of interoperability in development of digital solutions, not only at the country level, but also globally. Further, greater focus is required on supplementation of global investments instead of duplications in investments, and there is a need to create a unified global health architecture. Under the G20 motto of One Earth, One Family, One Future, India is working towards greater collaboration and sustained efforts across the digital health ecosystem. Leveraging its G20 presidency, India is also encouraging development of common global platforms for sharing of medical countermeasures, technical knowledge, digital infrastructure, and cost-effective digital health solution. I'm happy to note that this conference has brought together varied stakeholders from the global digital health community. These stakeholders must now ensure that the coordinated efforts are sustained and momentum but is carried forward. It should be our collaborative efforts to support each one at every stage for making these worlds a connected healthcare system without boundaries. Thank you. Thank you very much.
Thank you, Your Excellency, for highlighting the quantum leap that India has made and the many, many notable achievements that India has demonstrated, clearly indicating the digital prowess that this country has. I think this only goes, any tool that you're talking about and its application, when we hear the numbers, it is mind-boggling. It's always millions and beyond. So it's truly mind-boggling. And yet that it is being effectively implemented, I think shows how well it is thought of and how well it is being implemented. And I would like to commend Your Excellency for your path-breaking leadership in making or in ensuring that India achieves this. And all of us who are here in this room look towards that leadership and beyond. Now, I would like to request His Excellency, Mr. Joe Bejang, Honorable Minister of Ministry of Health of the Marshall Islands. We go from a very large country to a relatively small country, but even small countries do need the same solutions because people are same and health needs are same. Therefore, I would like to request His Excellency, Mr. Joe Bejang, to provide us or give us his thoughts or reflections and the experiences on digital transformation and the challenges and the vision and the roadmap that he may foresee as the Marshall Islands forges ahead. Your Excellency, over to you.
Thank you. Ladies and gentlemen, on behalf of His Excellency President David Kabua and the people of the Republic of the Marshall Islands, I wish to convey our appreciation to the Ministry of Health and Family Welfare. I wish to convey our appreciation to the Government of India and WHO Southeast Asia Regional Office for allowing the Republic of the Marshall Islands to share insights and inputs at this global conference on digital health. The Republic of the Marshall Islands is home to approximately 60,000 people, with over 20,000 people living abroad. It is located approximately midway between Hawaii and the Philippines. It is one of the most remotely situated countries in the world, with a total land area of just 70 square miles spread across 30 atolls and covering an area of 750,000 square miles in the mid-Pacific. The RMI also has one of the most widely dispersed populations in the world. RMI is facing a huge geographical challenge in ensuring taking UHC to the last citizen. Dealing effectively with our geography requires that we build both a robust digital and transportation infrastructure. Unfortunately, we are hampered by living with virtual monopolies, both in communications and air transport sectors, resulting in high cost and poor services, and together putting a major drag on our economic and social development. With transport costs so high, the development of digital health infrastructure offers major economic advantages, including the opportunity to target our services more effectively, to reduce the inefficiencies in management of medicine and supplies inventories. And through telemedicine, to reduce the need for medical evacuations and the hiring of in-country medical specialists. Despite the physical distances between us, we are making headway with our commitment to realizing the healthy islands vision and ensuring healthy lives, taking UHC to the last citizen and sustainable futures for all. Use of digital innovations such as digital health is one of the possible key solutions. The development of neighboring islands information and communication technology in the last 2 years have been successful with the installation of VSAT amongst 49 health centers out of 54. We continue to explore the needs of vast data sharing and collaborations of information between health services providers, clinics, and hospitals by updating and/or upgrading the systems and infrastructures. In fact, the RMI Ministry of Health Web IZ or immunization system transition from on-premises to cloud computing technologies were successfully implemented. Being on a cloud system with the presence of internet connection, it provides uninterrupted access for our immunization staff to our Web IC data entries, validations, and reports. Through other projects to support TB mass screening in the neighboring islands or outer islands, WHO and UNICEF donated tablets which allowed online, if available, if a Wi-Fi is available, or offline data collection of the screening, which will be uploaded to a centralized database. This data system, which was supported by the Taiwan government, also captures and sends off immediate X-ray results to physicians in the urban centers. Our ministry has been using this equipment for other outreach programs and consolidated data inputs such as for immunization program. Further, RMI has accumulated a good experience through emergency management of neonatal and obstetric care training to health assistants working in these outer islands where health assistants connect to doctors at a hospital in the capital city, which is Majuro, and get consultation, mainly by a radio call. This initiative was supported by WHO, CDC, Taiwan, and UNFPA. This kind of telehealth consultation has been useful to reduce the last-minute emergency referral as health assistant gets to advice by doctors, specialists early on. In general, internet connection in neighboring islands is gradually improving thanks to the development partners' investment. In addition to health centers, some schools in outer islands now also have internet connection. Recently, a joint communique between the Ministry of Health and the Marshall Islands Mayors Association in all the neighboring islands have been signed, which enhance better coordination with the ministry benefit health assistant to get more support from the mayors in partnership with the education sector. Beyond ICT infrastructure, I wish to also share the workforce development with the respect to digital health that has been placed. The training over the past 4 years of 4 successive cohorts of health staff in applied epidemiology and informatics through the delivery of the Fiji National University accredited data for decision-making program, available through our regional Pacific Field Epidemiology training program. We, however, continue to engage with multilateral discussions digital health. Recently, UNICEF is working with the ministry to administer a software called Rapid Pro, which enables a two-way SMS communication system that will be used as a reminder system for antenatal clients and routine immunization. Of course, none of these achievements or efforts are possible without the support of all of our development partners, including WHO, UNICEF, US, UNFPA, UNDP, and the Taiwan government. It would be remiss on us not to acknowledge their invaluable financial and technical assistance. In summary, RMI still has various challenges in implementing digital health in terms of infrastructure, that is internet and IT equipment, available workforce and their capacity, policy, strategies, and standards, fragmentation in health information systems, and etc. But there is an opportunity for a strong leadership and commitment by both the national and local government to utilize innovations, including digital health, to deliver quality care to those citizens living in the remote areas and outer islands. The vision and roadmap for the digital health transformation in the Marshall Islands. As stated earlier, RMI does not have a comprehensive national digital health policy or strategy, but our ministry's vision for the health sector is what we call Community Ejmur, or health is a shared responsibility. And one of the priority areas includes quality care in outer islands and access to care for communicable and non-communicable diseases, mental health and substance abuse, immunization, healthy lifestyle, preventive and public health, climate change, and health security. Because of our geographical challenges with the outer islands, digital health transformation will be inevitable to bring UHC to the last citizen. We can share one example of ongoing digital health transformation through a project supported by WHO. Through this project, we support an integrated TB and leprosy mass screening in the outer islands. WHO and UNICEF donated tablets which allow online or offline data collection of the screening results, which will be uploaded to a database that was integrated into the centralized database system supported by Taiwan government. Further, the data collection system was supported by the WHO CLO office, WebRo's IT department, which enables to collect a fingerprint of those people who come for screening. The strength of this data collection system is that every person is registered with a unique ID using fingerprint registration. The Ministry of Health and Human Services in the RMI has been using this equipment for other outreach program and also consolidated data inputs such as for immunization program and NCD screening. It is very powerful to have those equipment in the field, as health workers can immediately check the status of vaccination of children. For NCDs, it is also extremely important to follow up individuals for necessary referral and continuous NCD management at primary healthcare level. Having a unique health ID supports such provision of continuum of care. While people health program data information are being consolidated through such initiatives, there is an ultimate goal to link them to the electronic medical health records at a hospital through an unique health ID, which is yet to be realized. We are aware that all these interventions should not be implemented in an ad hoc way, but should be based on a coherent enterprise architecture for health information system in RMI. Building on all of these achievements so far, RMI is therefore keen to consider developing a national digital or e-health strategy, along with its implementation plan or investment roadmap to pursue a robust and sustainable digital health transformation for UHC. As it is also happening in FSM by WHO support, RMI is also interested in seeking WHO support to initiate a systematic telehealth pilot in one or two of our referral outer islands where a nurse practitioner is stationed and where it is expected to provide support to smaller health centers in the outer islands. Once again, I convey RMI's utmost appreciation and heartfelt thanks to the Ministry of Health and Family Welfare, the Government of India, WHO, Southeast Asia Regional Office for the invitation and allowing RMI to attend, participate, and learn from your experiences and successes. Thank you so much, Kamoldara.
Thank you very much, Your Excellency, for highlighting the many achievements that the Marshall Islands have made, and at the same time highlighting the many challenges in ensuring that no one is left behind in your attempt to reach healthcare that is of quality to everybody across the country. I would like to now move to the Regional Director, Dr. Poonam Khetarpal Singh. When the Regional Director took over as the new Regional Director in 2014, she presented to the region a vision of health, which she prioritized into flagships, initially 7, later adding another to make 8 flagships. The 8 flagships have been the focus and the core thrust of her leadership in CRO for the last now almost 10 years in this region. When the SDGs were launched in 2015, the 8 flagships fitted, the flagships fitted very well with the core thrust of the SDGs as well. And when WHO launched the GPW13, the core areas presented and covered under the GP13 also very well aligned with the flagships that Dr. Poonam Khetarpal outlined. I would like to ask you, Madam, how has digital technology supported and their implementation, and how it can be leveraged further in supporting member states to achieve further progress? Over to you, Madam.
Honorable Ministers, ladies and gentlemen, the moderator has already mentioned that, yes, in 2014, I did identify some priorities for the region with the member states. And the basis of that was that whatever we do in the region should not be spread too thinly, so that we have some programs that we can focus more on and then get results at the end of it. And what was the basis of identifying these priorities? Basically, we looked at the burden of disease, we looked at the CCS, the health plans that countries had, we looked at the WHO resolutions, both in the World Health Assembly and the RC. And what was very striking was that all countries, regardless of what stage of development they were in, economically, culturally, politically, or what their population was, the priorities that were outlined in the matrix after a very careful examination seemed to be across all the 11 countries of Southeast Asia region. And therefore, we started working on these, trying to see that a major part of our resources, both technical and financial, were focused on that. Now, what is the connection between that and the subject of today, which is digital health? Now, when we look back, we find, and the Honorable Minister of India has already shared, that how they use digital technology for RMNHCH services. We looked at that, we looked at the example of India, we could share it with other countries of our region, because I do feel that is also WHO's mandate, to pick up the best practices from countries, share them with other countries, so that they don't have to reinvent the wheel and they can proceed seeing what has worked somewhere will work for them. As far as these flagships were concerned, we saw successes in most of them. And just to name a few, in CDS, that is communicable diseases, we did focus on those diseases which could be eliminated. And we looked chiefly at measles, we looked at rubella, we looked at malaria, we looked at, other diseases like NTDs, because I do firmly believe that neglected tropical diseases are truly neglected. They are the diseases of the poor, and much focus is not given to them. In our region, we could have 14 eliminations across different countries. And I'm very sure if we did not have COVID-19, the list of eliminations would have been much larger. We also looked at NCDs, because there is more mortality from NCDs today than from communicable diseases. So it becomes an area of great relevance and importance to us. We find a lot of success in tobacco control, how that has been able to, the tobacco use has been reduced sharply if we look back the last 2 decades. And that is the success story in emergency management, which was another priority of ours and which COVID-19 brought to the fore. We saw in COVID-19, and it has already been shared by the Honorable Minister, the amount of teleconsultations that were done. 100 million teleconsultations in a country is really not easy. There are a lot of challenges there, but that could be done. I mentioned one, of course, there were many others which you've already heard about, And not wanting to duplicate or go into details, I thought it's important for us to just highlight some of these things that had been done. Now, COVID-19 also brought out the importance of digital technology, because that is when the realization came that digital technology is extremely important for the success of different programs of our region. Immunization is one such program, which was heavily dependent on digital technology. In our region, as far back as 2014, we had a strategy on e-health, and we worked towards it. In 2020, we have a global strategy for digital health. And in that, we find that the focus is more on what has already been discussed a lot yesterday, that is governance, data protection, collaboration, knowledge transfer, and human-centered health systems that would provide guidance and coordination on global digital health infrastructure and transformation. So that is where the stress is now. We also find that to support the implementation of the global strategy, a few innovations were brought about. Let me mention those. One was the Digital Implementation Investment Guide. Now, this is very important because we do understand that all countries of the region do need technical support, which WHO is very willing to give and is very forthcoming with. They also need financial resources. And this investment guide gives fundamental steps to support resource mobilization in countries and to see how they can successfully navigate the process from where they are today to where they want to be. We also had the Digital Clearinghouse, which will serve as a global framework on standards, promoting interoperability to support person-centered systems and continuity of care through seamless data sharing. And we've had several discussions on this yesterday also. It was highlighted that we cannot work in silos. Data sharing is extremely important. Interoperability is extremely important if we want digital transformation to really be there. Digital Health Atlas was also brought out, and this atlas is an inventory of important digital health initiatives across the world. As I mentioned, it's very important to learn from countries who have already been successful in certain areas rather than to reinvent the wheel. In 2021, WHO also produced guidance on ethics and governance of artificial intelligence for health. Artificial intelligence is talked about so much, and WHO thought it's important to have consultations with leading experts in ethics, in digital technology, law, human rights, as well as experts from the ministries of health. Working with them, the report identifies the ethical challenges and risks which arise when artificial intelligence is used for health. Moving forward, what is it that WHO needs to do? Moving forward, WHO remains committed to help member states in every possible way. And some of those mechanisms I have already outlined. WHO is working hard to reduce siloed approaches of digital health solutions, which can be counterproductive, and therefore to integrate them and to work together is extremely important. We don't want to duplicate efforts in a situation of scarce financial and technical resources. WHO will also continue to strengthen human capacity to enhance digital literacy and competency-based capacity, which becomes very important. This will help to galvanize the digital health transformation and reduce the risk and the frequency of investments in siloed disease-specific digital tools and structures. Finally, WHO will continue to facilitate global collaboration. Our role is very important as a facilitator, and that is what we will focus on. Strengthen global mechanisms to support the implementation of the global strategy through development of roadmaps by countries. And we are all aware of that. that strategies are easy to make, but unless we have roadmaps and unless we know how to proceed step by step on achieving what the global strategy talks about, it becomes extremely difficult to do that. So our next step is to see that countries of our region have this roadmap, and we will organize a meeting where we are going to talk about a plan of action. And that normally we do after a strategy is developed, because I do feel those steps are very important to achieve what we really want to achieve. So we will continue to strengthen human capacity to enhance digital literacy. We will continue facilitating global collaboration among various agencies in the digital space. We will strengthen global mechanisms to support implementation of the global strategy through the development of the roadmaps I just mentioned. And we will align WHO norms and standards to reap the full benefits of digital health. It has a lot of potential, and we can do a lot in that space. And that is what our thrust will be. Thank you, moderator, for your question.
Thank you, Madam Arti, for highlighting all the initiatives under your leadership that has taken place in the region of Southeast Asia. In addition, I'm sure the distinguished delegates from the countries here would be very happy to hear what WHO can do, such things as enhancing digital literacy, using WHO's technical capacity to build capacity in countries, and then helping countries develop a roadmap so that they can move forward with the implementation of digital plans, which every country has or are in the process of developing. So thank you, Madam, once again. Let us now move on to the speakers from the countries. I have first on my list, Ms. Nina Bergestedt, Senior Advisor, Office for Data, Infrastructure, Cyber Security, Ministry of Interior and Health, Government of Denmark. Innovation is one of the important pathways to the development and growth of digital health, both in terms of expanding the footprint and in terms of the impact on patients and citizens. What steps do you think should be taken to promote innovations in digital health? And do you see relevance of digital health sandbox for promoting innovations? Over to you, Madam.
Thank you. Good morning, honorable ministers, government representatives. First of all, thank you for inviting me to share my perspectives from Denmark, and congratulations to the organizers for a successful first day. I hope this will be as inspiring. I will share my thoughts on the steps to promote innovation and the use of digital sandboxes. In Denmark, we have a solid digital foundation that benefits patients and health professionals every day. We have in many years worked with digital strategies, and we are believed to be one of the most digital countries in the world. But we are facing a situation with more elderly, more people with chronic disease, and a shortage of nurses and doctors. So we need to do things differently, and we see a digital transformation is part of the solution. Digitalization has the power to change the way we deliver health service. And this burning platform is driving innovation. And I'm not so worried about innovation, developing new technology. I think that area is booming at the moment. The challenge is for the health system to adopt the new ways of working. So for me, the important question is, how do we promote sustainable innovation that are being implemented and are changing the health system? And I will highlight 3 aspects. Innovation must be centered around clinical needs and making the healthcare is efficient. We need to address that some digital solution creates overtreatment, takes time to document, and we don't have the resources to implement those solutions. And the way we have a focus on the clinical need is to have a better cooperation between private and public sector. I see that innovation often is generated from tech companies, from startups, from innovation organizations, and that is natural. They are trained with digital mindsets, innovation mindsets. Nurses and doctors, they are not trained innovators, but they are experts in clinical needs. So we need to bring the experts in innovation, the experts in clinical needs together to build an ecosystem between the private and public sector. The third aspect that I will highlight today is, as a member state of the European Union, the coming regulation of a European health data space that are being negotiated actually these days. This regulation will have a massive impact of the health system in the European Union. It's providing rules of individual rights to data, common infrastructure, standards, to share data in member states, but also between European countries. This is very ambitious, but if it succeeds, it will enable innovation through easier access to data. So I would suggest you to have an eye on this regulation. So my closing remarks is on the use of digital sandboxes. And I see a potential in using sandboxes in developing, especially data-driven new technology. The European General Data Protection Regulation is necessary for protecting the sensitive health data, but it is often seen as a barrier working with small-scale innovation projects. In that aspect, digital sandbox can be a solution. We have in Denmark been working with synthetic data. This is data that are generated from computers, but they look like real data. And this makes it easier dealing with the data protection, working with, for example, AI. I also do see some challenges that need to be addressed working with sandboxes. And I think the difficult part in implementing new technology, it's the changed workflow, it's trusting the evidence, and we see a cultural resistance. And we see this, we call not invented here syndrome, that organizations may avoid implementing things that are not coming from themselves. So the challenges with digital sandboxes is that the solution, the project is tested away from the organizations that has to implement it. And that can be a challenge in implementing the innovation. So we need to take care of that. So just to sum up, innovation is crucial for making health sustainable, but we have to focus on the clinical needs, making the health efficient, and it has to be done in a close cooperation between public and private sector. Thank you.
Thank you very much, Ms. Bernadette, for your thoughts on the potential value of digital sandbox, and also sharing your thoughts on how we can support the development of digital health. I would like to now turn to my neighbor here, Mr. Badr Aulathani, Director General of Information Technology from Oman. A complex program like digital health requires multi-stakeholder approach. What more do you think global organizations like WHO should do to accelerate the adoption of digital health? Over to you, sir.
Good morning, everyone. Your Excellencies, participants from all the countries, online and here in Prims. I would like to congratulate to Government of India, Minister of Health, really for the achievement has been done in terms of the digital health. And really we're feeling proud of the yesterday I'm sharing the information about the digital health and the achievement has been done in these countries, and we're wishing all the best for the next period of times. When we talk about, I'm going to come back to about the questions, but let me briefly talking, when we developing the digital health solutions and the initiatives for all the countries, we should keep in consideration the patient expectations. So this is the journey started. It's not starting from the ministerial levels. We should start it from we are the normal peoples, and we used to to take the facility from the government. So the digital solution should be started from the patient expectations, because the patient's journeys, it's starting from the birth until the death. So if you imagine that the informations which is already gathered from the birth until the death, it is a huge information. And that information, it is not linked to the Ministry of Health only, because the other stakeholders also, they are waiting and they are looking forward to get that information to make the decisions and serving the citizens to get the services. For example, if the birth notifications, it is not shared with other stakeholders and the government, again, they cannot make also the planning, for example, the vaccination programs, the other. So I'm going to elaborate a little bit about the experience of Sultanate of Oman and what we did it before 20 years ago in terms of the digitalizing the institutions of the ministries. We take the decisions of developing our in-house systems, HIS system, health information systems. It's called the Shifa, and the systems now it is working in around 279 institutions in Oman, and that really make us a more strength of developing the other supportive systems, because we have a base, and the base is available to be used for that institutions. So after that, after we did our implementation of the 279 institutions, we moved to the supportive systems, and the supportive systems which already link with the HIS systems of referring patients, and also the notifications, communicable diseases notifications, and the others also supportive systems which helping the practitioner doctors to make their decisions. So after that also we move to our HIE systems, and HIE systems also already developed in-house, and already it's covered now more than 200 institutions, where we're exchanging all the informations in one warehouse. So that all the elements and achievement has been done, really helping the country to develop the mobile application and a mobile health. Now we are moving to mobile application where our patients, our citizens and residents, they can view the informations from the single systems. They can book appointments, and also they can generate all the informations available belong to the patients and citizens. Again, to the questions, how the WHO is, accelerating and helping the countries to develop. Of course, really the WHO, they are doing the great works. Is not now, since I have been attendance of the digital workshops and seminar of the WHO, and really it was the hot discussions about how to helping the country to move forward about the digital health. So I think that the COVID-19 is the game changers for all the countries. The COVID-19 giving the countries to speed up the digital health. So the change management is very, very important in all the country to be adopted, because we see that the resistance is there from all might be the stakeholders when we're talking about the digital health, but that can be addressed by the change management program strategy to address and to accelerate the digital health. Also building the capacity of the human resources. This is very important, because when you're developing the systems, don't think the systems are going to develop it and implement it, and then you forget about the enhancing the systems. The enhancement of the systems, improvement of the systems, and the solution should be continuously, should be also aligning with the change in all the countries, because there is the change in the healthcare facility is there. Also is we know that in the COVID-19, it was the difficulties and the challenge of the cross-boarding of the data sharing informations, especially when you talk about the COVID vaccine pass, when the travelers moving from one country to another country, it was really the difficulties for some of the travelers to share the information, to authenticate that certificate of the COVID-19. That should be also addressed. And I suggested to the WHO to discuss about thinking further of exchanging the information between the country to another countries. Regarding the investment and financial models, that also already elaborated and already addressed. And this is very also important to be considered about the sustained model to be cover all the digital initiatives of the strategy. And also we should think about not duplicating the work. This is very, very important to be considered, because we saw that there is a lot of the initiatives, a lot of the experience of the country in the digital health. And we request WHO with collaboration with all the countries really to support the other countries who is required the help and the support in terms of the digital health. Again, the strategies, when we doing the strategies, we should doing the national assessment of the gap analysis and the national assessment of the systems, because that is very, very, very important. When you talk about the stakeholders who is providing the healthcare, you know that we have a different type of the stakeholders in the countries, starting from the government to the private, for the military, and the other also society who providing the health services. Because the patient is the patient, he's moving from one provider to another provider. But at the end, if the information it is not shared between all the stakeholders, that it will affect the decision making of the treatment of the patients, and also the planning for the future for enhancing the services. I would like to thank you very much for giving me this opportunity to talk, and wish you all the best.
Thank you, sir, for your excellent talk. And we take note of those areas where your suggestion for WHO to support countries in that. Thank you very much, sir. Let us now move to Mozambique. I would like to invite Mrs. Bernardina de Souza, National Deputy Director for Professional Health Training, Ministry of Health of Mozambique. I understand that Ms. Bernardina would have interpreter support. So may I know? Oh, okay, so we're all set. All right. Please, madam, over to you.
Bom dia a todos. Excelências, prezados dignatários, caros colegas.
Good morning to you all. So all the ministers here and everyone.
É com grande honra que me apresento a esta magna conferência global sobre a saúde digital em representação do nosso país, Moçambique.
It's a pleasure for me to be here and representing Mozambique.
Queria também aproveitar esta oportunidade para agradecer à Organização Mundial de Saúde pelo convite que nos foi feito e também ao nosso país anfitrião, Índia, através do Ministério de Saúde, pelo caloroso acolhimento que nos deu.
I would like as well to thank WHO for inviting Mozambique to be here in this conference, as well the India for receiving Mozambique.
Moçambique tem uma população aproximadamente de 32 milhões de habitantes e abraçou o Ministério de Saúde em 2018 a plataforma da telesaúde.
Mozambique has about 32,000 million inhabitants and has embraced the health system in 2018.
Dentro daquilo que é a plataforma de telesaúde, o Ministério de Saúde abarca 3 áreas, a dizer, a teleconsultoria, a telegestão e a teleeducação. A telemedicina ainda é um grande desafio no país.
Okay.
Queria dizer que nós abraçamos a 3 áreas, nomeadamente teleeducação, telegestão e teleconsultoria. A telemedicina ainda é um grande desafio.
Okay. I'd like to say that we embrace 3 different areas, the telecommunication, but the telecommunication is still a problem for us.
Foi-nos colocado uma questão: que tipo de apoio os governos precisam para garantir que os investimentos externos e domésticos em sua transformação digital de saúde sejam eficazes? Como é que os nossos governos poderão ter, dentro daquilo que é o apoio externo e doméstico, para que essa transformação digital seja eficaz no país?
Okay. One question was put to Mozambique, how the telecommunication can help to solve some of the problems related to the health system.
Tendo esta questão, eu colocaria alguns pontos para que, de fato, a transformação digital, da saúde digital, seja efetiva no país. É necessário que o país tenha uma política de saúde digital efetiva.
Okay. First of all, to solve one of the problems, what we really think is the necessity of the country to have an effective digital healthy policy.
Para além da política, nós temos que ter a regulamentação. Sem esta regulamentação, nós teremos muitos desafios, como já vemos no país.
So, and also we need to have the regulation that is still not there and has already caused some issues regarding to it.
Dentro do país, nós já começamos a ver várias iniciativas individuais. Cada instituição vai fazendo a sua intervenção, mas não existe algo que é regulamentado e harmonizado dentro do país.
Okay. We still see that some providers are still doing the work, but they are not connected between them.
O segundo aspecto é o investimento na infraestrutura, no equipamento e também na comunicação para o sistema de informação digital.
Another one is the investment in the infrastructure, equipments, and communication and the IT system sector.
Nós, como Ministério da Saúde, colocamos algum equipamento ao longo do país, principalmente para atingir as zonas mais remotas. E porque há províncias que não têm nenhuma possibilidade de ter acesso.
Okay. The government has already provided some of the population with the service, but it is still on the remote areas or the most rural areas that do not have the contact with the technology.
Outro aspecto é o investimento de recursos humanos para esta área, mas também como fazer a sua retenção no sistema de saúde.
Another one is the investment in the HR on the healthcare system, and also how can
the workers could be retained and also be educated to continue the work.
O outro aspecto é a criação da capacidade de cultura digital.
The country doesn't have like the cultural digital idea. So to build and work to capacitate the people on the digital area.
Nós dizemos isto porque ainda há uma grande resistência de usar estas plataformas da telesaúde ao invés de fazer formações, portanto, treinos presenciais.
We still have some resistance of people about the use of the communication for the online capacity.
A criação da capacidade de condições no setor de saúde para responder às preocupações dos doentes, a capacidade de consultas entre os clínicos, pois a nossa população, maior parte, 85% acima dele, usa ainda os cuidados, portanto, os cuidados de saúde primários.
Okay. Educate the health workers on the health units to provide the best to their patients. And still we have 85% of the population who is still using the service.
E não menos importante, nós dizíamos a largura da banda para a internet e a falta de rede celular avançada como o 5G.
So to highlight it here is like Mozambique is still not have a great broadband service like 5G, but it makes it very difficult to have the broad or to get in contact with as many part of the population as possible through the digital area.
A percentagem da nossa população em termos de usuários da internet ainda anda por volta de 20%.
So only about 20% of the population has access or use the internet in Mozambique.
Portanto, estes eram os aspectos que eu queria partilhar com esta Assembleia sobre as principais áreas que nós gostaríamos que o nosso governo tivesse apoio para a sua implementação efetiva. Nós podemos dizer, na altura da Covid, da pandemia da Covid, vimos o grande desafio e a grande vantagem que tivemos com a formação dos clínicos para o diagnóstico e tratamento portanto, da doença por Covid-19.
During the COVID, so we could see how technology really helped on the treatment or to how diagnose and how to educate the front line to serve the population as better as possible. And with that, so Mozambique could save a huge amount of money and as well use the technology to better the service to their patients.
E podemos observar que durante a pandemia de Covid tivemos a oportunidade de formar aproximadamente 2.000 colegas da área da saúde e com esta formação através do Zoom online conseguimos poupar aproximadamente milhão de dólares.
Throughout the Zoom, so Mozambique could educate 2,000 people that were on the front line. And with this, though they had a saving of $1 billion that could have been, that is going to be used in better other parts of the necessity of the country.
Por isso, está claro, e nós estamos comprometidos como país a avançar com o apoio de todos vós para podermos alcançar esta meta, que é ir até ao último, portanto, elemento da nossa população na área mais remota do nosso país.
So with that, we really hope to get the help of all of you to really provide the health until the most remote part of our country.
E muito obrigada pela atenção dispensada.
Thank you all for the attention.
Thank you, Madam, for sharing your thoughts. And I would like to thank our interpreter for her service. Greatly appreciated. May I now turn to Dr. Preeta Rajaraman, Health Attaché and Regional Representative, U.S. Department of Human and Health Services, Office of Global Affairs, Office of the Secretary, U.S. Embassy in New Delhi. There is a consensus on the pivotal and critical role of digital health that digital health can play in transforming health services. Can you provide your insights on the key enablers of digital health, for instance, policies on data protection, data sharing, telemedicine, etc.? Over to you, Madam.
Thank you so much. Excellencies, dignitaries, colleagues, and friends. Let me first express our deepest thanks to the Government of India, the Ministry of Health and Family Welfare, and the WHO Southeast Asia Regional Organization for gathering this wonderful group of policymakers and implementers to highlight the essential role of digital health in accelerating progress towards universal healthcare. This is a promise that we witnessed in real time when we saw the power of digital innovation to tackle the formidable challenges of the COVID-19 pandemic through platforms such as CoWIN, eSanjeevani, and so many more. But even before, and certainly beyond the pandemic, digital health and innovation have become increasingly critical to a strong healthcare system. We've seen the evolution of these technologies over the last decade, from very simple patient portals and basic electronic medical records to a much larger ecosystem that includes healthcare devices, telemedicine, artificial intelligence, machine learning, comprehensive data science, and so much more. But in order for these technologies to reach their full potential, we need to have some key enablers in place. We've already heard many examples of these during the discussion yesterday, this morning. We know that we need to create a policy framework, use evidence and evaluation to ensure safe, quality products, address privacy, security concerns, ensure interoperability among systems as well as nations. And last but not least, engage healthcare providers as well as consumers to ensure true value to the end user. Within the United States, these different enablers of digital health are largely addressed by agencies within our Ministry of Health, the Department of Health and Human Services. At the federal level, policy recommendations for telehealth are largely led by the Health Resources and Services Administration, or HRSA. Data privacy and security, interoperability, and the standards-based exchange of health information are led by the Office of the National Coordinator for Health Information Technology, or ONC, and many of you in this room have worked closely with them on digital health. Innovation and development, on the other hand, including those technologies that accelerate the response to emerging threats, are supported by the Biomedical Advanced Research and Development Authority, or BARDA, as well as the National Institutes of Health. And the US Food and Drug Administration provides regulatory oversight over digital health products, Now, I want to pause a moment here because we heard about the balance that we need to have between this very, very rapidly growing field of innovation and the need to regulate, when necessary, products for patient safety. And so the FDA very intentionally has developed a risk-based approach for this, which allows swift dissemination of low-risk products across underserved patient population, but also ensures appropriate regulation of those products that are medical devices with patient safety implications. So this means even for products which incorporate artificial intelligence and machine learning, FDA has an action plan which creates a more nimble review process that incorporates planned future modifications, such as changes in algorithms. And this approach allows for the improvement power of artificial intelligence and machine learning while still assuring patient safety and not overburdening the field. And finally, the Centers for Disease Control and Prevention leads the creation and use of data for evidence-based, rapid, actionable public health decision-making. In plain language, the CDC focuses on making sure that the right data are in the right place at the right time, but also make sure that trained personnel who know how to use these data are in place. In the context of the pandemic, we found that additional flexibilities were needed to address the country's urgent healthcare needs. So through the COVID-19 Public Health Emergency Declaration, the US introduced more flexibilities in technology development, released some of our geographical use restrictions, and increased the types of reimbursement for telemedicine and other kinds of digital health initiatives, which resulted in a 63-fold increase in telehealth use through Medicaid and a nearly 60-fold increase in virtual visits at HRSA-funded community health centers over this time. Moving to an international setting, the US strongly supports digital health as an accelerator to universal healthcare. US domestic agencies that promote digital health all have extensive work in partnership with countries and international organizations to advance joint digital health priorities, as does the US Agency for International Development. You heard several examples of USAID's excellent work in India yesterday. So let me add just a few more examples from some of our other agencies. So CDC, in partnership with the government of India, focuses on skills and capacity development to operationalize digital health initiatives, whether this is through telementoring of clinicians to strengthen TB and HIV management, to improve antimicrobial surveillance or infection prevention control, which is closely related, using digital platforms, training of frontline health workers on the strategic use of data for decision-making for outbreak response through initiatives such as the Field Epidemiology Training Program and others, or lab system strengthening to improve data reporting to the Integrated Health Information Platform. Our National Institutes of Health fund several collaborative grants between Indian and US researchers to support novel digital systems that help prevent, detect, and respond to a range of diseases, including deep learning for improved detection of cardiovascular disease using a digital stethoscope, low-cost mobile platforms to screen for pulmonary disease, oral cancer, cervical cancer, and mHealth platforms that improve referrals to treatment from community health workers. In fact, India, the United States, and the WHO were among the 14 founding members of the Global Digital Health Partnership in 2018. And that feels like a very short time ago. This dynamic collaboration facilitates global collaboration, knowledge sharing, and the design and delivery of digital health services to support high quality, sustainable healthcare for all, and has already grown to include 33 countries and 3 international organizations. The 4 work streams of GDHP are very much focused on how do we strengthen these enablers, whether they're policy environments, cybersecurity, evidence and evaluation, clinical and consumer engagement, or interoperability. So in conclusion, whether we look at this from a national, a regional, or a global lens, The implementation of digital health has already immensely strengthened health systems. And yet, the future potential promises to be even more transformational. We, the United States, look very much forward to working with India, the WHO, and our regional and global partners to unlock this exciting new frontier. Thank you.
Thank you so much, Dr. Rajaraman, for your thoughts and sharing your experience and the policies and strategies that the USA is following. We are now to the last speaker, and I would like to invite Dr. Benoit Savaroche, the first Counselor, Health and Food Safety Delegation of the European Union to India. Over to you, sir. The question for you is, what are your suggestions for promoting such environment which is person-centric for health intervention? What do you think are key steps required to enhance the trust of the citizens in digital health solutions? Over to you, sir.
Thank you very much. Your Excellencies, esteemed participants, dignitaries, colleagues, friends, I'm really grateful to the Ministry of Health and Family Welfare and the regional office of WHO for organizing this conference, where so many brilliant minds can exchange on their thoughts and experience. I'm very happy also of the questions that you chose for me, where I can share some elements which are very relevant for the European Union. I would start by mentioning that in December last year, the European Union adopted a declaration of digital rights and principles. And this declaration started with the first principle, which is the digital transformation must put people at the center. And therefore, despite the fact that it's not specifically for health, your question on person-centric development makes a lot of sense to us. What we mean by that, what does that mean, people-centered, or that we want a democratic framework for the development of digital transformation, meaning that we want consultation and participation. We heard many of the principles discussed during these 2 days. I will not continue on safety, security, privacy, but there are some other elements which have also been mentioned, such as inclusion, inclusivity. We heard some countries talking about the fact that you need infrastructure. So that's part of these inclusions, that you have access to all, but also that we also address all the categories of persons, including the most vulnerable or the elderly, or those who lack skills or even literacy. And there are aspects that need to be taken as well. Another of the principles that has been mentioned in this declaration is the sustainability. And when we hear sustainability, we think, of course, environmental sustainability, but we have also social sustainability and the impact that it has. So you see, despite the fact that it's a European declaration, what we heard yesterday and today is that these are values and these are fundamental rights and principles which are commonly shared across the world. To answer specifically your questions, so what can we do to ensure or to develop trust? I would say that there are 3 things that we should do. The first one is to address in a transparent way the risk that we identify. The second one is that we promote and communicate on the benefit of the digital health. And the third one is to develop a series of tools that will help addressing and implementing what we want for this human-centric development. On the first one, on the risks, again, we spoke about security risks. So, for instance, how do we ensure continuity of care in case of ransomware of hospitals, for instance? Or how do we ensure to avoid data breaches and cyber criminals attacking the data banks? On privacy, I would like to take one example on the COVID crisis. You may remember that several countries developed what we call COVID trackers or individual trackers for COVID. And there, in many jurisdictions, people were asking questions on who has access to this data, how long is it retained? And therefore, it's very important to develop a framework and legal safeguards against unlimited access to personal data, be it from private entities, but also for governmental entities, where it's needed to develop concepts such as purpose limitation or proportionality. That's for the aspect of privacy. On the aspect of safety, we heard that WHO and also UNESCO have developed, for instance, these principles, on the ethic of artificial intelligence, to develop elements of safety, which would include, for instance, explainability or human oversight for those who adaptation or for those use which would create risk on safety. But there is another element on risk that I would like to develop, which is the dehumanizing aspects of digital health. I think we've heard it from Oman and also from Mozambique that there is reluctance or resistance to go there, and we need to understand why. And I would like to take another example, which is the case of Ebola crisis in Guinea and Sierra Leone, where we understood that actually by not taking into account the essential elements of social science, such as giving the last right to the diseased, we had actually hampered the control of transmission of disease. And therefore, it's very important to include social sciences in this development of digital health. And we are here one of the living examples that telemedicine may not be always, I mean, the ideal solution. We could have had this teleconference instead of meeting together. So we need also to take that into account, into the resistance to understand how we can best develop that. But we have also the benefits, of course, primary benefits. Everybody said about the development for the universal healthcare access. I mean, being it here in India for leapfrogging, but also in Europe, where we have the problem of medical deserts and the aging population and the difficulty to reach in person. So there is this benefit, but the benefit of quality of care. And for instance, in EU, we developed specific networks, international networks for rare diseases, and therefore the importance of interoperability across borders as well for exchanging on this health data. But that's for the primary, but the secondary use of this healthcare, which is, and it was mentioned, either for research purpose or for policy-making purpose. Here we have the issue of data. Who owns data? I mean, what is the ownership? Who will give the authorization? So the aspect of consent of use of data, but also what we're developing in the EU as regulation is the concept of data altruism. By communicating, by explaining what you want to do with the data, you may actually get, including individuals or private entities, to develop and to share their data for a greater common good. And therefore, we need an element, a complete set of tools to implement this person-centric development and develop the trust. I've mentioned, of course, a number of laws, regulation, standards that are necessary. But for the implementation of those, you need also possibly authorities that will check, I mean, the implementation on day-to-day. It can be also a contact to the consumers or to the citizens. And I would like to finish with that. You may also benefit from actually the digital sphere also as a tool. And here I refer to the digital public infrastructure, which are also promoted by the government of India in the G20, and one in particular, which is called the Data Empowerment and Protection Architecture, DEPA, which is giving to the citizen, to the individual, the control of their consent of sharing data at a granular level. And I think by sharing this experience, we can become collectively wiser in order to develop a true human-centric digital health environment. Thank you.
Thank you, Dr. Savaroj, for that very enlightening discourse. I think we are a little behind time, but I would say that this has been an extremely rich high-level plenary that we have had. I would like to thank His Excellency, the Honorable Union Minister of Health and Family Welfare, Dr. Mansukh Mandavia. I would like to thank Mr. Joe Bajang, Honorable Minister of Marshall Islands, our Regional Director, Dr. Poonam Khetarpal Singh, and the country delegate, Ms. Nina Bergestedt, Ms. Bernardina De Souza, Mr. Badar Awalathani, Dr. Preeta Rajaraman, and Dr. Benoit Savaroj for being here on this panel and sharing your thoughts. I will not attempt to summarize all the rich discussions that have taken place, but I want to emphasize or reiterate one point which Dr. Savaroj started when he opened his speech. I think one common thread that ran through all the discussion and the talk is that technology is good, innovations are necessary, but people must be at the center of it. And I think that is the common thread that ran through all the discussions today. And with that, I would like to hand the mic back now to the MC. Thank you very much.
Thank you very much, DPM. Thank you very much, distinguished delegates, Honorable Regional Director, and Your Excellencies. Ladies and gentlemen, as we understand, we are a little behind schedule. So I will invite you to take a 20-minute break to enjoy, after the warmth of wisdom on stage, this a steaming cup of universal health beverage, which is tea, in the Allure Hall. And I would request you to be back in 20 minutes, which is 11:15. Thank you so much.
लड़के को बुलाओ, पानी टेबल से चेंज करेगा, बोल दे उनको।
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation response.
Santa bastante depurali la chungitani was hogu santa kudang ni saban taro kadur kite anke wastan santa santa tiwai
presentation. Okay, so I need to be off stage when you call me, right? I am Ruchira. I don't know. I assume I'm the first one.
And just already we shall here.
The laptop?
They all will be seated. It will take about 5 minutes and then the moderator will call you.
Traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव से आए सयान सजनमन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार रक्तचाप की जांच और उपचार मधुमेह की जांच और उपचार शिशुओं का टीकाकरण गर्भवती माताओं का टीकाकरण का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें.
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare.
Ladies and gentlemen, may I request you to be seated, please, as we begin the second session of the morning.
चार हाट बाजार लगता है जिसमें हम लोग हाट बाजार में आते हैं जिसमें
Ladies and gentlemen, distinguished delegates, honorable participants, welcome back to the second session, second calibrated session of the day. Allow me to welcome at this session on innovations for UHC, the keynote speakers, Mrs. Ruchira Shukla, Regional Lead, International Finance Corporation, Global Sector Lead for Health Tech. Please welcome Mrs. Shukla on stage. Our next keynote speaker, Mrs. Yasmin Das Guche, lead health systems in transformation for the World Economic Forum. She is going to join us virtually. Our ministerial delegate, Mrs. Aishat Shamia, Permanent Secretary from the Ministry of Health of the Republic of Maldives. Please welcome Mrs. Shamia. And our partner organization representatives, Mrs. Shibu Vijayan, who is Medical Director for Global Health, Cure AI. Mrs. Vijayan. Mr. Vijayan. My sincere apologies. And Mrs. Rigveda Kadam, who is, just give me a moment, who is Deputy Director for Digital Health, FIND from Geneva, Switzerland. And may I welcome Mr. Kiran Anandampilla, Senior Advisor for the National Health Authority, to moderate the session. Welcome, Dr. Anandampilla. Ladies and gentlemen, I shall be doing an extremely difficult thing, that is to remind our distinguished delegates that something more omniscient than health and universal health coverage is time and its relentless march. We are a little behind schedule. I would request you sincerely to keep an eye on the clock as the day proceeds. Thank you so much, and over to you, moderator, for this distinguished panel.
Thank you. Good morning, everyone. As we have been reminded, it is a panel that we have to keep the time short on, so I'll jump right into it. I'm really happy to be moderating this session on innovations in UHC. We'll start with Ms. Ruchira Shukla, regional lead from the International Finance Corporation, where I would request Ms. Shukla to actually talk about how the International Finance Corporation is looking at funding innovations in UHC. Over to you, ma'am.
Thank you. Delighted to be here. Let me just quickly set this up. Yes, you guys can see this. Let me begin by sharing with everybody what is IFC, what are we as an institution. For those who may not know, we are a member of the World Bank Group, which is the largest DFI globally, and we have been working in emerging markets for the last 60 years. We've invested over $300 billion and have over 4,000 people across these different markets, AAA rated, and continue to focus on developmental impact as well as private sector growth in these countries. This is an image of the different entities under the World Bank Group. What's commonly known as the bank is the IBRD. And as you can see right there, IFC is one of the divisions under that umbrella. IFC's value add. So when we become active in an emerging market, our focus is to drive private sector development. And we do that through various ways. It's almost a twofold intervention. We want to develop private sector, we want to develop different industries through advisory initiatives, as well as support their growth through investments. And what's unique about our value add is we work very closely with stakeholders across the spectrum, whether it's industry associations, government entities, bureaucrats, to help shape forward-thinking regulation that could drive the sector towards growth. We bring in a lot of global industry expertise. We have a network of executives across these different emerging markets. We have companies, over 2,000 companies that we have backed and supported, and we bring in learnings from those endeavors into our initiatives. We also do a lot of what we call upstream support. Upstream support is focused on finding spaces which need development and going in there with initiatives way before capital can follow, and helping structure those spaces in a manner that become investable. We provide long-term funding. We are the one-stop shop, which can bring funding across instruments. We can do equity, debt, quasi-equity investments, and we can do longer investment horizons, which can help support these sectors through various ups and downs. We pride ourselves in being counter-cyclical. So when things go difficult for a particular sector and private capital usually shies away, is when IFC comes in there to invest more capital. I talked about our value added through advisory. We have a global presence and we're able to do both US dollar financing as well as local currency financing. So that's IFC in a nutshell. I'll go into what we've done in emerging markets healthcare, from there into health tech and some of our priority segments for investing for innovation for universal health coverage. In terms of the healthcare dynamics, some of these factors have been highlighted in the last 2 days. There is an increasing demand for healthcare needs across the world. And there are a number of factors driving that. The world population itself is growing and is expected to grow to 9.5 billion by 2050. And with that, there will also be a 3x rise in the number of people above the age of 65, which in turn implies a 5x increase in healthcare needs. And there's also a shift in disease profile. You know, we had a lot of conversation around infectious diseases over the last few years because of COVID. But what we also see increasingly dominating is the non-communicable diseases. And that's happening because of poor lifestyle, poor nutrition, and that is causing premature death, premature disability. And this is going to increase more so in developing countries than in developed markets. Also, with the need for more and more healthcare and the limited resources in developing economies, we find that private sector and out-of-pocket expenses becomes the solution to deliver healthcare. And a lot of emerging markets have very low penetration of health insurance, because of which there is an increasing willingness to pay, but also an increasing burden to pay on private sector and on the actual consumer. The supply of health services remains challenged. Many emerging markets will not have in the foreseeable future enough physical or human resources to meet this increasing healthcare burden. And we see that there is therefore an expansion, a need for innovative business models. We've seen a push towards telemedicine, e-pharma, and new models of remote and hybrid care that came to the forefront because of the impetus provided by COVID-19. The rollout of vaccinations across various nations exposed the challenges in supply chain. And we saw AI, IoT, and data science play a very important role in managing the spread, in monitoring the disease profiles, the insights into which patient segment was being affected more than others. We've also seen genomics play a very important role. And finally, regulation. As we all know, we're here because regulation is pushing for more universal health coverage, and PPPs will become increasingly important. I'll skip past this slide in the interest of time, but the data is well known that when you look at any metric of health supply, whether it's beds per 1,000 people, physicians per 1,000 people, a lot of emerging markets lag behind developed economies, while at the same time having an increased burden of out-of-pocket spend. However, this presents a unique opportunity for emerging markets to leapfrog using technologies. It would be very expensive and almost impossible for emerging markets to follow the same model of care that developed economies have done, because they would never be able to spend as much. But with the use of technologies, they have the potential of leapfrogging and delivering better outcomes at lower cost to their populations. I'll talk a little bit about IFC's health experience. So IFC has been investing in health since 1998. And we have invested over $6 billion across 57 countries. And that investment has been spread across health services, pharma and biotech, as well as medtech. And as I was saying earlier, we not only invest capital, but we also support with various value creation and advisory initiatives. And I've shared here selected examples. Putting in place a framework for ethical practices in healthcare was one of the initiatives we undertook, where we put in 10 fundamental principles to be shared across the healthcare ecosystem and encouraged the companies we were working with to sign up for these principles and the adoption of these standards. IQ Healthcare was another tool that we developed to help emerging market hospitals and clinics raise the standards of quality and provide quality assurance and patient safety initiatives to the populations they serve. So we set the standards, we've deployed these tools, and are encouraging the companies we work with to adopt them. Here below in the slide is a list of health tech investments that we've undertaken over the last decade. You will see their names like Portia, NephroPlus, IQ. These are assets that were delivering quality healthcare using technology. Tata 1mg is an asset that delivers integrated digital health, which includes teleconsultations, e-pharmacy, e-diagnostics. Sala Uno and CDA are assets we've backed in Latin America. Sala Uno is an eye care chain, and CDA is a chain of facilities that delivers diabetes care. And finally, MedGenome, one of our most recent investments, provides genomic services across South Asia and is building the largest database of South Asia demographic as well as genotypical, phenotypical information. I emphasize this one because world over, a lot of genetic data is focused on Caucasian populations and largely male populations. So a lot needs to be done to diversify that database, because that data feeds into drug discovery and that data feeds into standards of care, but it's not based on a diversified data profile. These are some of our indirect investments. And what I mean by indirect investments is IFC also supports venture capital funds and PE funds. And through the 19 funds that we have invested in, actually we've invested in 250, but 19 of them have active focus in health. You can see the 68 assets that we are exposed to indirectly through those VC funds. And they span various sectors. So there's data analytics, AI, virtual care, femtech, genomics, other health services, pharma, and biotech. You can also see that that portfolio spans various different geographies, including East and South Asia, Latin America, MENA, Africa, and global solutions. We've also pioneered and undertaken an initiative that was called Tech Emerge. Tech Emerge was focused on discovering innovations in health across the world and bringing them to emerging markets to encourage adoption by the health service providers in those markets. What we did there was we invited applications by these innovators and then connected them to health service providers in the country. This was done through a very methodical approach where we figured out the awareness gap, the know-how gap, and the financing gap, and then invited applications in those segments. Why it was unique? Because it was very driven by the needs of those economies. It was fair and impartial because it allowed any innovator from across the globe to apply. And it provided risk mitigation measures because in connecting these innovations to the service providers, we were able to define and structure pilots, several of which were funded by IFC to encourage early adoption. And finally, we gave the leadership and support to see some of those pilots become commercial contracts. So we are the convener, the curator, and the matchmaker for technologies from across the world for health service providers in emerging markets. And in taking that role seriously, we've taken this initiative across various countries. These are the different geographies in which Tech Emerge Health was rolled out. It started with India, followed by Brazil, and then East Africa. And it has led to several innovating companies seeing commercial contracts in these geographies. I'll now move into the healthcare priority segments and the strategic considerations that IFC has in undertaking health investments. So these are some of the focus areas we look at across the healthcare space. The big one there from the top is data analytics and AI. We're increasingly entering a world where there is a lot of data being captured in disparate systems on human health. And there are solutions that leverage their data to provide superior diagnostics, superior therapeutics, superior path of healthcare delivery to patients across the life cycle of the disease. And we are looking to identify innovators there and back them through both capital and advisory support. The second segment there is virtual care. Virtual care speaks to teleconsultations, e-pharmacy, and supply chain digitization across various subsegments within healthcare. And we have backed, as I was saying, 1mg as the first player already in our portfolio, but then looking at several others that are digitizing B2C care as well as B2B2C care, which is connecting the different stakeholders that come together in providing healthcare. Femtech is another increasingly important area because we see women and children being left out from the care that is being provided. And there are several women-focused, female-focused diseases that tend to be ignored. And there are now increasingly solutions that are software-based that can improve access and quality of care to women and children. So that is another third pillar of our focus. And the last one there is genomics and point-of-care solutions. Here we are focusing on portable devices, portable solutions that can leverage data to then provide disease diagnostics in hard-to-access remote locations and at cost and price points that become affordable. Finally, the last row there is what we call sandbox. These would be advanced technologies, perhaps very early in their development, but would have the promise to improve care and better outcomes down the road. This includes things like blockchain for tracing and tracking drug delivery, drug movement. We saw a lot of solutions doing that for vaccines over the last few years. Robotics in surgery, robotics in various kinds of health interventions, 3D printing of various tools that are needed for healthcare, virtual reality in the surgical room to allow interventions, to allow training of healthcare professionals, drones for delivery of essential medical supplies, and several examples there of company logos where companies are using these technologies to provide viable solutions in emerging markets. These are some details on the 5 segments I outlined. Very dense slide, forgive me for that, but I've covered most of the points as I was presenting, so I'll skip past this one. And lastly, some of the considerations. So health businesses take longer to scale than other sectors. So certainly health requires more patient capital, and it requires capital plus, which means it requires not just the financial support, but the advisory, the convener, and all the stuff we've been talking about to make these solutions viable. B2C models can get highly competitive, and generally they then suck in a lot of capital. And we've seen some B2C companies with high cash burn, which again increases the need for patient capital, but also implies that it can become very hard to scale because of the competitive intensity. And we've seen that there's increasing need for all stakeholders to come together: insurers, employers, telcos, health providers, policymakers, etc., to make these innovations viable. The categories we avoid as IFC is offline-only services. We feel a lot of capital has already gone in. There's public sector capital available for offline services. So that's a space we've stayed away from. We haven't avoided it completely, but we don't focus on that under the health tech umbrella. IFC, I must emphasize, has a separate arm which does offline health services investments, and that falls under our manufacturing, agri, and services department. So it's different than health tech, but we do support them. We just don't put that under the VC and health tech umbrella. We avoid asset-heavy business models because that can, again, require a lot of CapEx and take time to scale. We avoid business models that have binary risk like pharma, biotech, discovering a unique molecule. And because we're IFC and we're a division of the World Bank, we avoid solutions that are focused on the rich. So the high-end upmarket solutions are those that we avoid. But across the board, there are several things we want to do, and we are very happy to be part of events of this nature, like today, where different stakeholders get together to join hands to make a difference in this increasingly important sector. Thank you. Thank you for having me.
Thank you, Ms. Shukla. I think we can all agree that health tech innovation is going to be very key for LMICs to actually leapfrog in delivery of care and to deliver care at a much lower cost than their developed country counterparts. And innovation cannot happen without funding. So health tech innovation really requires both risk capital as well as long-term capital. And it's great to see IFC doing that in that space. I was also really good to see that they have adopted ethical principles, which they're working with their investees, as well as they're trying to make sure that adoption happens by bringing these innovations to healthcare providers. So thank you so much for those insights. I think PPPs came up even in Ms. Shukla's talk, and we have Jasmine Diaz, the lead health system transformation from the World Economic Forum, joining us online. Hi, Jasmine. Can you hear us?
Good morning. Yes, I can.
I think we can't hear you. Either you're on mute or we
Hello?
need some tech support.
You hear me now? Good morning.
Yes, we can hear you now. So look forward to your talk on what the World Economic Forum is doing with PPPs.
Excellent. Thank you. Let me just set up my screen real quickly. Waiting for just oral confirmation that you can see my slides.
Yeah, the screens are up. The slides are there.
Thank you so much. So again, good morning, all excellencies, distinguished colleagues and friends. It's really an honor to be a part of this important conversation on digital health, and a pleasure to be here with you all today representing the World Economic Forum. As said, my name is Jasmine Diaz-Guichot, and I am the lead of Health Systems Transformation on the Healthcare and Healthcare Platform. Again, thank you for inviting me for sharing some of the work that we're leading and how we're thinking about creating access and reaching that last mile through innovations in digital health and public-private partnerships. It's really been wonderful to hear about all of the collaborations already taking place, but I wanted to share with you all additional opportunities because the forum's health and healthcare platform really does have as a priority to bring urgency on how we can transform health systems. And as we've seen through the last several years of global shocks, public-private partnerships are so important as they are vehicles to really address the challenges in different areas. They combine the nimbleness and innovation of private companies, along with the civic vision that governments provide. So in the spirit of facilitating these partnerships on the most pressing global challenges, the World Economic Forum, the international organization for public-private collaboration, is really dedicated to working with our global community of stakeholders to incubate and scale initiatives that brings health to every citizen. So just for a bit of context, at the World Economic Forum, we see our role in three main areas. Firstly, to build awareness and shape the agenda. Here we gather leaders to exchange insights, both within the forum's community and among a broader global audience, like we're doing here today. And then we use this awareness to inform decisions and guide strategy. Lastly, we use this awareness that we have built alongside the informed strategies to drive collective action and impact. So in other words, our convening role helps to amplify and scale up the world's strategies and bring people together. One silver lining from the pandemic is that we forged these new kinds of public-private partnerships and started to work together differently, using innovative ways to tackle complex problems. So we really believe it's paramount that we never forget the effect that the pandemic has had on health systems and the immediate impact on the populations. But we also remain ambitious in our actions and commitments to ensure that health systems remain resilient in the long term. Improving health and providing access to equitable, high-quality healthcare is a shared global concern. This is not only a social and ethical imperative, but essential for the stability, long-term development of our economies, societies, and achieving UHC. The Health and Healthcare Platform houses several initiatives that address these issues of ensuring that digital health is accessible, equitable, and improves health outcomes for all. So together with our health-minded partners, we create impact on our platform. And to execute on this task, we've uncovered major trends of our health and healthcare spheres. So we address the issues of preserving health, system strengthening, digital transformation, and emergency preparedness and response. With all of our initiatives, we really try to emphasize the long-term focus of transformation, that healthcare is an investment and not a cost, that good governance and early action from governments and private sector stakeholders can really help build this sustainability and resilience. So here we're addressing some of the many factors that contribute to the challenges of reaching the last mile, including inadequate health infrastructure, insufficient health workforce, limited financial resources, and inadequate data on the health status of underserved populations. Our Global Health Equity Network aims to shape a healthier and more inclusive world through mobilizing executive leadership and commitments across sectors and geographies. The network aims to get businesses to integrate health equity considerations across their core strategies, operations, and reporting. So getting them to invest in health equity beyond the basic CSR and philanthropy. Leaders here work towards systemic change through a strategy that places health equity at the center and drive change in 4 specific yet very interrelated domains of action within their organization, through their offerings, in communities, and via broader ecosystems. This is to ensure that that last mile is taken care of. And one of the important taglines that we like to use here is that every company is a health company, and that each organization has the power and responsibility to make a difference. Next, I'd like to share a little bit more on how digital health transformation can be used to improve the quality of care while increasing efficiency and reducing costs. So here, the work undertaken by the Global Coalition for Value in Healthcare looks to address system strengthening by using value-based healthcare as this vehicle for change. This community uses the shown value-based healthcare framework that helps keep patient outcomes as the priority. This framework shows different levers of change that in an orchestrated way will be able to improve patient outcomes while also keeping in check budgets and available resources. And one of these key enablers is informatics and health data, making sure that systems have the underlying infrastructure that ensures interoperability, standardization, patient privacy, and security, along with good governance. But we also have our Partnership for Health System Sustainability and Resilience. This work was established in 2020 and is a global collaboration working with governments and healthcare systems to shape the future in a post-COVID-19 world. The work here aims to build health system resilience to withstand future crises and sustainability to improve patient population health in the long term. The mission here is to provide tools and resources for research, a focal point for collaboration and knowledge exchange within and between countries, and a platform to disseminate and catalyze the adoption of breakthrough insights. The research here is done alongside our partner, the London School of Economics, and it has already been done in 20 countries. We're counting and adding more to the list. So our country level reports focus on the 7 domains listed, one of which is medicines and technology that really aims to assess how health systems make use of medicines and information in the delivery of health services. And this includes how they use digital health. So the goal here is to take stock of the successes and challenges in order to better fill the gap. But as seen, we're also undergoing an exercise in digital transformation. Access really is one of the most critical goals for us, in addition to outcomes and equity, as previously noted. We believe technology can be a really major enabler to improving access and driving towards UHC. However, we do think that it needs to be closely tied to systemic changes involving people, as mentioned in the previous presentation, processes, metrics, and other aspects. So digital transformation of healthcare will require a really broad array of holistic solutions and long-term changes. So we're orchestrating here a number of strategic projects with partners to address transformation from multiple angles and perspectives. I'm sharing here 3 of the major initiatives which are being scaled to address this. Firstly, the Digital Health Action Alliance is leveraging innovations for prevention, diagnosis, and treatment of non-communicable diseases. In healthcare digital transformation, we're looking at the application of emerging and frontier technologies that are data-driven, really linking to global goals. And we're also working very closely with the Edison Alliance and our Centers for the Fourth Industrial Revolution. The C4IR network is this global platform for helping leaders anticipate technologies and also accelerate their inclusive, sustainable adoption. The platform on data policy aims to unlock the value of data for all by increasing collaboration, developing these policies together, and strengthening action across data ecosystems. So for us, it's really important to emphasize the need for healthcare stakeholders to work together and find a common mission. As the forum truly believes, change can really only occur when everybody comes to the table together. So reaching that last mile and providing access to quality healthcare services, especially to underserved populations, is really at the heart of the work that we do at the World Economic Forum. So the request here is that governments, donors, and all other stakeholders come together to leverage the potential of emerging technologies to improve health outcomes for all. In the end, we're all connected. So with that, I really just want to end by saying that we must think beyond what we can do alone and recast our ambitions of what we can do together. Thank you so much for your time today, and really appreciate the World Health Organization's and India's leadership in this transformation journey. And I would really invite each of you to join us and welcome you to collaborate. Thank you.
Thank you, Yasmin. That was a really interesting presentation. It's great to see how the World Economic Forum is pushing every company to think and realize that it's also a health company and how its work actually affects health outcomes for everyone. Also great to see how the World Economic Forum is actually asking all of us to work together, because innovations requires every one of us to kind of come together. I'd like now to move to the ministerial delegates, and we have Asiyat Samia, Permanent Secretary to the Ministry of Health, Maldives, with us. Can I please request her to talk about the innovations, digital innovations that you have experienced in Maldives?
Good morning, ladies and gentlemen. In my presentation, you've heard that in the yesterday and today's sessions, there are many ways which we can use innovation in enhancing health and well-being of populations. Today, we will bring a different perspective. You've heard a bit even in the morning in the ministerial session, keeping the patient at the center. Could we please share the slides? This is not covered in the presentation, but I think as I've got some time before we share the presentation slides, Maldives is also embarking on using drones to share samples between the islands because it is very difficult to create a laboratory on each inhabited island, but rather to improve access. There's a lot of technology which we could use to bring these services closer to the people. So with the support from some of the donors, this year we are going to introduce drones to bring in samples and medicines to the rural areas from the urban areas. Thank you. So today in the presentation or in this session, I would share Maldives' glimpse on how innovations are used to improve universal health coverage. Let me begin by posing this question to the audience. So what distinguishes a winning digital health innovation that genuinely solves problems from many that will fail or worse, create new problems? So as we embark on digital innovations, it is very important to know how what the issue is and how what the intended outcome is from the digital solution. As I said before, the perspective that we would bring today is how digital health innovations could be used to leverage patient engagement. How can we use digital solutions to empower patients, to improve the self-care of patients, and also putting healthcare in the hands of the patients? Do we do enough in this regard? And why is this important? We've heard about this in the morning session as well. As bureaucrats, as policymakers, we tend to think or design digital solutions around healthcare providers or policymakers or to aid us in decision making. But at the end of the day, it is the patients who are the most important stakeholders. So we should always keep them in mind when we develop or when we embark on digital solutions. There's many ways which we can use digital solutions to aid in universal health coverage. But today in this presentation, in this session, we would bring in 3 cases. Case number 1, going back to the COVID pandemic times, where there was lots of restricted movements, where there was increased demand for testing, and there was a need to disseminate the results to each individual or most of individuals in the community. Most of the mitigation measures were highly dependent on the test results at the time. And, timeliness was critical. So every decision depended a lot on the test results or how fast we can convey the test results to the public. There was a lot of information given to the public in different ways. So the public was aware as to what action was to be taken. But we need to get the results to the public for them to change their action or to take the right action at the right time. Because if we are late in sharing these information with the public, it means the spread would be more. It will be difficult to contain the COVID-19. Also, as with most other countries, there was very limited human resource capacity. Even though the case numbers were increasing at an alarming rate, the human resources was not increasing at the same pace. So it was the same human resource attending to the huge number of cases. And this led to innovation. We've heard from other countries' experience as well. So one of the solutions which there were many solutions, but one of the solutions which we would share today is the adoption of a digital platform to access test results. So rather than us at the emergency operating center calling each patient to give them their results, the platform enabled public to access verified test results. And this later on evolved as the COVID safe platform for the public. So it's not only for the results, to share results, but to share other information critical for the public, for their decision making, including the vaccination status. This is the first page in the portal, which gives information to the public. It has to be user friendly if it's for the public. Gives information to the public, engages the public, and then it goes to the page where you get the results. Again, very user friendly, very clean, not much information, and you can also print the information. We find that some in the public, like elderly, they still want the hard copy of the results. So COVID-19 was a calamity, but as they say, there's a silver lining in each cloud. So this was an impetus to take us forward. We've done much more than what we've done over decades, over few years. The health providers are aware that it is possible to share data on a daily basis, on a timely basis, and then it actually not adds to their workload, but it reduces their workload. Now the public is also aware that it's okay to have their information on a digital portal, and they've also learned to use digital portals. So this paved the way for more innovations in healthcare. The second case which I would share today is what we faced was there was a lack of an easy mechanism to access vaccination records of a child. People were using manual vaccination records. In the country, most people come for deliveries to the tertiary level in the central, and then so they get their first dose of vaccine at birth in the tertiary hospital, and then later on they move to their island. So there's a lot of movement of the patients, and the patient or the relative is tasked in the system to carry the manual record of the vaccination. So what happens if the vaccination card gets lost? It's a huge burden. It's a tedious task for the health provider because they have to go through the manual records and they have to verify the information and give the information to the public. And from the patient's perspective, it's a much more complex task because they have to go to different facilities. It's not one facility which they need to go. So they need to go to different facilities, get the information of this one patient's record. The solution which we've given to the public is the adoption of the Maldives Electronic Immunization Registry, or the EIR. EIR is designed with a beneficiary portal as well. So it's not only for the health providers, but it's also for the public. This is the view for the health provider. So you can see there's lots of information on the slide. So the need for the health provider, information need for the provider is different. You can see in the next slide, this is the view for the beneficiary. So it looks very similar to the manual record, which they are very familiar with, so that there's more acceptability from the public. You can see at the top of the slide that if you have 3 children, then you can toggle between the records of the three children. And then, so we are looking at the second child in the middle here. Very, very easily you can see that the child is 3 years, and the only remaining vaccination is the vaccination that needs to be given at 4 years. You can also see at the bottom, travel vaccination and other vaccination. I would take you to the last case, which I would share today, is we've moved over the years from a very primary healthcare based system to a more curative based system. So most of our health providers, we expect the public to come to us in the health facilities. At the same time, as we've heard in the other presentations, there's a high burden of non-communicable diseases. So there's about 80% of our deaths are attributable to non-communicable diseases. And what happens is when you wait for the patient to come to the health facility, when you wait for the patient to come to you, it's detected at a very late stage. So the need currently is to scale up early detection for timely intervention and also to empower lifestyle changes from an early on stage. So the solution we've brought to the public is a primary healthcare module, an NCD platform, which collects information at individual level in the community. So rather than waiting for the patient to come to the health facility, healthcare teams go to the communities, go to the homes, and we collect information of each individual above 18 years of age. So the risk factors, NCD risk factors of each person above 18 years is already collated into this module. And there's automatic calculation that happen to determine the risk level, NCD risk, the CVD risk, so that it guides the health providers to take the right action at the right time, to also focus on patients or communities which need more health interventions. It also guides the public to make the changes in their lifestyle at the right time. So on the slide, this is just a summary from the portal. So once you enter the data, once you get the blood results and the BP levels and everything is entered into the system. So this is a 53-year-old person. You can see on the slide that he or she doesn't have asthma, COPD, but you can see at the top that the body mass index is on the higher range. So body mass index is BMI is in the overweight range. The CVD risk, we use the heart package, and it's in the medium range. You can also see that the NCD risk score is also in the moderate level. The NCD risk score is a local base criteria which we've developed based on risk factors, 5 risk factors or 5 risk indices. You can see that at the bottom, even though the person is classified as having diabetes, as having hyperlipidemia and hypertension, the individual is not on medication for diabetes or hypertension. So it's this flags to the health provider as well as to the individual that there needs to be changes at the right time. So we, from the health provider side, we can give, if further investigation is needed, this highlights it as well as start of interventions in lifestyle changes. So on a concluding note, I would leave behind with 3 remarks. Number 1, we talk about digital innovations, and it shouldn't be from the providers or policymakers' perspective. It's important as well, but then more importantly, it should benefit the individual in enhancing their health status. Number 2, digital innovations should be designed with interoperability in mind. Why? Because different countries approaches digital solutions in different ways, but it should be designed in a way it enables, maybe not right now, but at a future date to enable a comprehensive record of an individual with longitudinal tracking of health status. So that should be the ultimate aim when you are designing these systems. And lastly, health security and data protection. We've heard in the earlier session, it's very difficult to give confidence to the public that the data, your health data, which is very confidential, is the security and data protection is ensured. So you might not have all the answers with you, but you could work with the experts. So we are also engaging in our digital journey with experts like from the National Center for Information Technology, and working on the necessary legislation, the Health Information Act, the Data Protection Act, as we go along our journey. So this is just a photo to bring calmness to your mind. Thank you again for your attention.
Thank you, Ms. Samia, for that really wonderful presentation. It was great to see how you're not only talking about keeping the patient at the center, but demonstrating that with 3 different applications from Maldives related to COVID, electronic immunization, and NCDs. I would like to now move on to the partner organizations. So we're going to start with Mr. Shibu Vijayan, who is the Medical Director of Global Health from Cure AI. And dear Shibu, if you can talk a bit about how Cure AI is actually using AI in radiology and where you see that going. Thank you. It's not coming up. It directly changes.
Good afternoon, everyone. So thanks for giving us this opportunity. I'll be speaking about our product portfolio. And about how it is kind of deployed, the various use cases, and how it is deployed in various settings. Predominantly, our dominant deployment is on X-ray, and that is in the global health space for tuberculosis detection and related lung diseases. So mostly my presentation focus will be on that. So Cure AI is an AI-powered radiology interpretation solutions. We have necessary regulatory approval from FDA. Recently, we got a CDSO licensing, and it's deployed across 100,000 plus sites across 70 countries. And in the global health space, it is around 50 plus countries. And we do have we are one among the largest data sets used for training. So from 4.5 million data sets are used for our X-ray training. And we do have 1 billion data sets, including our, which is our mission to actually reach out and then solve the global health issues. So this is our product portfolio. As you can actually see that, okay, it starts from the predominant solution is the lung health. Essentially, the QXR is complete X-ray reporting as a solution with 30 different X-ray readings with an auto reporting capability, which is auto-populated, and the doctors can actually see and edit it. So that adds value to, and also annotated diseases like tuberculosis, lung nodule with a cancer malignancy scoring, and cardiac failure. So we are also working on interstitial lung diseases and COPD and pneumoconiasis, which are in the pipeline. So similarly, our QER suite is actually made for our CT scan head, which also flags brain injuries, including brain bleeds, hydrocephalus, midline shift, and accordingly quantify and triages and helps in taking decisions. And we also have a CT scan chest, again, similar to the lung X-ray, that's chest X-ray, which also identify early lung nodule with a malignancy scoring. Again, that will also help in triaging and following up the patients. So we have a solution for extremities, the lung, so the bone extremities images for reading mild fractures, not extensive fractures, which helps in, again, triaging the emergency room with a less than fully qualified staff, which they can actually identify small hairline fractures and then accordingly escalate. So this is our most popular solution, the X-ray AI solution. As I mentioned, this is again FDA certified. This is CE class 2B certified. And it's been deployed in 1,000+ sites with almost 4.5 million training data sets, which detects and localizes 30 different chest diseases. This exactly works like a radiologist looks at an X-ray and see findings, and this will get auto-populated. The findings get auto-populated at the right side of the window. And then doctors can actually see and then accordingly edit and download the report and sign it. So the major use case of it, as I mentioned, is in the screening program. So, and this has been evaluated by WHO through FIND, and WHO collaborated with us along with Stop TB and evaluated as a screening tool, and it's been documented and in the WHO consolidated guidelines for screening for tuberculosis, and also mentioned in the handbook. So these are different use cases for our chest X-ray. One is the normal versus subnormal, which is predominantly used in the Middle East for migrant screening, Malaysia for migrant screening, and also the teleradiology services. So in the teleradiology services, this gives more bandwidth for the existing radiologists to read more X-rays, because so this comes with the high accuracy in identifying the normals. So in most of the cases where we see is that 70% of the X-rays are normal, and then the doctors can actually spend less time and then have more number of X-rays being read. So the lung cancer, as I mentioned earlier, so we do have an early lung cancer. I'm not talking about the extensive lung cancer or the late stage lung cancer. These are capabilities of identifying smaller nodules we can intervene early on and then make the patient outcome better. So the lung cancer detection with a quantification of the malignancy scoring. And tuberculosis, which is the predominant deployment, again, looking at the consolidation, cavity, pleural effusion, and different abnormalities. This indicates a probable tuberculosis, and then subsequently can be confirmed by a final diagnosis through a molecular test or a sputum testing. In the ICU, it also we have a solution for the feeding tube and the bronchial tube positioning, which helps in the ICU doctors for whether the tube is in the right position or not. In the emergency room for X-ray specifically, again for any chest fractures and pneumothorax, which could also be identified and then could be escalated. Heart failure is a function of cardiac megaly and also pleural effusion. So we have all these solutions which I mentioned here been validated in different stages and being deployed in different settings. So this is our Cure app platform, which is yesterday also Santosh Matthews mentioned during his talk over here, the importance of care coordination and real-time information sharing for quick decision making. So this is one of the capability of which we are offering along with our solution. So which enables to share the CT scan images and the report, and also any lab report, disease modality or even test report or disease agnostic platform. This has been now deployed in Jammu and Kashmir, and doctors are actually can see the report from the home and take decisions and convey that to the patients, and then and also take decisions. So this is more like a WhatsApp chat, group chat, wherein we can share medical information across this, and also also act as a PAC system. So the PAC system is one of the, so if you look at PAC system in the developed countries or even in India, where many places, it is actually very expensive. This is a low cost PAC system which enables to kind of share and radiology information system as well as clinical decisions. So a couple more innovations. So I just described about the product portfolio, the lung and the CT scan. Now I am talking about innovation. So whether this is, so why I am talking about innovation within an innovation of AI, so the community or the health needs in the health system might be different, and all the health infrastructure is something very important about when we think about digital health. So once we had that system of AI and then went to the field, we realized that there is a huge dearth in having digital X-ray in the health system. So there comes in India Health Fund and then supported us to nudge us to develop a system for analog X-ray reading. So this works exactly like you can take the printout of the X-ray and put it under the film, can you put it under the light box, against the light box, and through a mobile app we designed could take a photograph, and in fact, what we are doing is that we are digitizing the image, and that enables to read it through our existing AI, which we have validated with the conventional digital X-ray reading versus the analog reading, which is kind of matchable, and which we presented that in multiple settings also. So that is one innovation. The second innovation, which is typically the AI reading or X-ray AI reading, is being used for active case finding or a remote setting where there are no radiologists or doctors are not available. So most of our deployment in African region are essentially for remote active case finding, either be it in a nomadic setting, be it in a hilly terrain, be it in an indigenous population screening. However, Mumbai Corporation actually come forward and in partnership with Stop TV Partnership requested us, like, can we deploy the solution in high footfall hospitals in Mumbai Corporation? They selected around 6 hospitals, and then all the X-rays happening, chest X-rays happening there. So believe me that this is not for TB screening. This is for any X-ray, any referral pathway happening there will be screened by a AI. And in that, the workflow starts in the X-ray department. So the X-ray department, most of these facilities have one X-ray facility, and most of the referrals are coming to that place. And so we call it a surveillance model, but we found 35% of the extra cases. When I say we, the Mumbai Corporation found 35% of extra cases among the diagnosis was from the non-TB referral pathway. So if you think about a surveillance model which can unlock diseases like tuberculosis, unlock diseases like lung nodule, unlock diseases like cardiac failure, and when you saturate this technology across a geography, there's an immense potential of finding hidden cases, immense potential of finding early case finding, and immense potential of linking them to services, and then decreasing the healthcare cost, adding efficiency, and also kind of providing services to the population. So that is the 2 innovations which I would want to mention within our existing innovations. So these are just the deployments during the COVID time. So before COVID, we were just a 30-member team, a small Indian startup. Now we are almost 250 members. Like COVID and the digital revolution happened along with that, also kind of taken us into that highway. And now we have COVID and TB bidirectional screening supported by UHC, and has been deployed in almost 52 plus sites, and 75,000 plus scans has been done so far. And that also, so any lung health and the COVID solution have a efficiency of progression monitoring. Now we are actually leveraging that learning to actually look at whether TB progression monitoring could also be built in as a solution within our existing solution. So we are compatible to multiple hardware. So this is an exclusive software company which I am representing. We need a hardware to kind of function in the setting. So we work with digital ultra portable X-ray manufacturers like Fujifilm, MinX-Ray, and MyLab. We also deployed it in the Everest base camp to difficult terrain, and we also have outreach camps in South Africa and Nigeria and in Haiti presence. We do have an in-cloud deployment and an in-premise deployment and offline deployment. You can see a small box there, which is actually a compressed CPU, which is our offline deployment solution, which comes with an extra cost. So that is broadly our innovation solution. Happy to answer any questions. And all our developed country deployments are for stroke management, lung cancer triaging, and teleradiology optimizations. Thank you so much for giving this opportunity.
Thank you, Vijayan. That was a very interesting talk, and it's fascinating to see how AI has moved really fast in the radiology space, and really interesting to hear that 35% of screening in Mumbai came from the non-TB pathway. Now going to invite Ms. Rigveda Kadam, who's the Deputy Director for Digital Health at FIND. FIND has been working with many innovators to scale point of care diagnostics. So love to hear how they're supporting the innovation cycle.
Thank you. First of all, I would like to thank the organizers, Ministry of Health and Family Welfare and the WHO CRO office for convening such a timely and productive gathering, and also for giving us the opportunity to present. So as a preventative measure against dropping blood glucose levels in the room, I'm going to keep the presentation really short. I'll speak about who FIND is, just sort of examples of diagnostic innovations across the patient journey that we have seen, and then specifically as what are the enablers of scale up that we see for innovations. So getting right into it or not. Okay, there we go. So FIND is a nonprofit. We were founded in 2003. We are a WHO collaborating center for lab strengthening and diagnostic technology evaluation. And we are also one of the co-conveners of the ACT Accelerator Diagnostics Pillar along with the Global Fund. We connect countries and communities, funders and decision makers and healthcare providers to solve diagnostic related challenges across low and middle income countries. Specifically in the context of digital health, we've worked across the past 20 years to support digital diagnostic innovators via technical assistance as well as in-kind and funding support on product development. We work closely with policymakers both at a global, regional and national level for evidence generation and regulatory capacity building, and with national lab programs as well as diagnostic private sector programs for capacity building. I think we've heard often enough now how COVID-19 has spurred digital innovations, but just to sort of paint a before and after picture. Prior to the pandemic, if you look at a typical patient journey for getting access to diagnostic results, it would start at a community level where someone would feel unwell and then would have to travel to a primary healthcare facility, which might not even be at a close distance to them, at the risk of losing their daily wages, to get a rapid diagnostic test. Depending on the disease or depending on the health condition, they would then be referred to a hospital or a lab for a confirmatory test. With of course, COVID-19, as one of my previous panelists said, there is a silver lining where now we have a multitude of innovations and innovators who are focusing on simplifying the health journey for patients with the overall intent of moving quality and timely diagnosis closer to patients. So all of the examples that you see here on the slide, and I'll speak to them very quickly, are actually commercialized products that have been deployed across the world. Starting at a community level, there are innovations like chatbots, WhatsApp-based chatbots, for example, that have been used by the government of South Africa to provide timely information on when to seek care for COVID-19. There are also AI-based symptom screeners like the German innovator Ada Health, which are also moving symptom screening and triaging into the hands of patients. Then we also have smart thermometers that are freely available now on Amazon US platforms, where the data that is collected in an anonymized and aggregated manner is not only used to inform, of course, the patient themselves, but at an aggregate level is also used to inform trends and inform surveillance decisions. At a primary healthcare level, as Dr. Shibu already spoke about, there are other inventions like artificial intelligence-based chest X-ray image analysis that can inform TB screening and diagnosis, TB being the topmost infectious disease killer across the world. Then there are, of course, both AI-based as well as non-AI-based clinical decision support tools, and one of which I think you can see at the booth outside as well. Then there are the use of point-of-care diagnostic technologies like ultrasound machines that are also available with and without AI, but with the overall intent of making sure that the consistent shortage of qualified healthcare workers that we are seeing is addressed, to make sure that the healthcare workers have enough time to spend with the patients, that the more transaction-heavy tasks are automated to the extent possible, and the entire patient and provider experience is streamlined. At a hospital and a lab level, we've already heard a lot about eSanjeevani and the way telemedicine was really able to bring diagnosis and overall healthcare service delivery closer to patients. Then, of course, we some of us saw the National Public Health Observatory yesterday, where the data from different health services as well as different programs is aggregated in a manner that informs policy decisions on a daily, weekly, and also on an annual basis, both in terms of infrastructure, in terms of financing, with the overall intent of making sure that patients are receiving the care that they should. So now that, I think nobody is debating here that innovations haven't happened. And but I think one point to sort of wrap that up would be, I'm not sure if you can see the numbers, but this is the number of commercialized FDA approved AI-based tech. Now, just to sort of paint a picture, prior to 2 years, these would be around some 100 plus solutions. At this point, there are some 500 plus solutions that are available in just one country, with the bulk of it being around radiology. So just to sort of put a number on when we talk about that AI innovations are booming, digital innovations are booming, we are not talking about like tens or 20, like some minor numbers. We are talking about thousands or even more of such innovations coming down the pipeline across all country settings. So what is it that we can do as an enabling ecosystem to support the scale up of these innovations? Because at the end, if the innovations haven't impacted patient care, then really they haven't really lived up to their true potential. So this is a figure that demonstrates what are the typical valleys of death that innovators face when trying to scale up their innovations, and what also end users or health programs face when trying to adopt innovations. While this started out as more of a non-software based valleys of death representation, you will see that most of these are applicable to digital innovations as well. On the left-hand side, we have some sort of drivers of valleys of death around evaluation and around like weak fit with the user needs, as well as then a disconnect between the design process, where we are trying to involve the user, and then the actual development process, which is handled separately. On the right-hand side, then we have the lack of focus on once innovations are available. It's not as if people would be just sitting around to try and scale them up or try and adopt them. There is a consistent approach to change management, as well as trying to understand the social sort of approach to getting people to use these innovations. That's also needed. Then, of course, I think especially with the Global Digital Health Initiative, you would see that a number of these drivers are already going to be addressed, especially around the weak engagement of country decision makers and the lack of planning and resources for country adoption. But with all of that, I think taking Dr. Khetarpal's comment and Mr. Love Agarwal's comment to heart, which is what is it that we would like to see in the Global Digital Health Initiative? And this is my final slide. Here are some suggestions for this group to consider. The first one is around innovation and product development priority areas. So while we are talking about consolidation of different digital health investments because of fragmentation, I think it's also important to keep in mind that we need to clearly articulate as a community, especially based on country feedback and user feedback, what are the gaps that still need to be addressed by innovators, and what are the product development priorities that should be prioritized for further investment and research and development. The second component has been debated at length on this dais as well as within the room, which is, of course, the regulatory and policy environment. I think this is a tricky balance to figure out, where the intent is to make sure that the innovations are sort of performing the way they should, and also safeguarding that should not mean that we are looking at a regulatory life cycle for 2 years, by which then either the innovators have gone bankrupt or the software itself is outdated. I think the FDA and also to some extent the IVDR have done a lot of groundwork already in figuring this out, and especially with also the digital health sandbox that's being proposed as part of the Global Digital Health Initiative. We are hopeful that there is some clear direction available to innovators on what they need to generate as evidence to make sure that they are adopted at scale. The third component that I want to mention is data governance as well as access to data. So we've spoken about how data needs to be collected and managed in an ethical, transparent manner. But I think one point to also note is that all AI-based innovations right now are being designed around whatever data sets are available publicly. And so if there is a misrepresentation or a bias in those data sets, let's say if they represent only a certain set of the population, we are inadvertently leaving behind some of the population segments, and most probably these are vulnerable population segments who are underrepresented in these data sets. So what can we do to make sure that at least from in these ethically sourced data sets, there is that representativeness and fairness? And the final suggestion from our end would be, I think it's important to create success stories that people can use to visualize what, when everything that we are asking for gets done, success looks like. I think an exemplars or like success stories that demonstrate what an end-to-end digital transformation would look like, either in a district or in a particular site or in a use case, would go a long way in helping people and stakeholders from across sectors understand why digital health and digital health transformation is important. And one such example would be integrated disease surveillance, where you would have the opportunity to connect communities to healthcare service providers to the national disease programs to demonstrate how actually streamlined data pipelines can create a public health impact. Thank you.
Thank you so much, Ms. Kadam. It was eye-opening to see the pace at which AI is really moving, 500 plus innovations, almost 392 of them in the radiology space, and also reminding us that to prevent innovations from dying in valleys of death, the need for both regulation and data governance to keep pace with how it happens. I think very important even for India to have that happen. So with that, folks, I think we have had an amazing session with a lot of very interesting insights on what it takes really to keep innovation going. I don't know if we have enough time for any Q&A, if somebody can let us know. Otherwise, we can bring this session to a close. All right, so we have been given 5 minutes before we let you guys go for lunch. So if any of you have any questions for any of the panelists, please go ahead. Looks like lunch is calling. All right, with that, let's bring the session to a close. Thank you all.
Thank you very much, distinguished panelists, for your erudite discussions. This is a pre-prandial session. May I invite you to lunch without much ado. Since we are going a little over time, I sincerely will request you to be here to start the session at 1:30 sharp, at the half hour past 1 at this venue. Ladies and gentlemen, thank you so much. Enjoy lunch.
Taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development, all ready to go, will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Wellbeing for All to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government's actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
Santa bastante depurali la tumitani mas fogo santa kudani ni saban taro kadur kite anke bastan santa santa tiwai santa.
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव गांव से आए सयान सजनमन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार रक्तचाप की जांच और उपचार मधुमेह की जांच और उपचार शिशुओं का टीकाकरण गर्भवती माताओं का टीकाकरण समस्याओं का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें.
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है जिसमें हम लोग हाट बाजार में आते हैं जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते जो मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं. तो गर्भवती महिलाएं आती हैं उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं. जो इंटीरियर से गर्भवती महिला आती हैं उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिलती है.
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Haat Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल. ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं. और जो हमारा पीला वाला कार्ड है ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं नियरेस्ट जो PSC CHC रहेगी वही बेचते हैं.
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है जहां तक हमको हमारी सेवाएं नहीं पहुंच पाती हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन इस बाजार के दिन में हमारी वहाँ स्वास्थ्य सुविधाएं हमें प्रदान की जाती है.
Mitanins, also known as Ashas or community level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते तो बाजार में जाने से क्लिनिक खुला है वहाँ जाके चेकअप कराइए सब बोलते हैं.
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया. जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है. निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है.
मेरे को परेशान बहुत ये जितना महसूस था ये पैर महसूस था
ये पूरा शरीर सब मोटा मोटा था। मेरे को यहाँ पता चला शुगर बीपी बोल को, अभी तब से वो दवाई मैं लेता, अभी तो रखी था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Basar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
Santa bastante depurali la chumitani mas fogo santa kudan ni saban saro kadur kite anke bastan santa santa kiwai santa.
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly heart bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव गांव से आए सयान सदन मन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करे।
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है, जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो अब मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं, उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिलती है।
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Heart Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CSC रहेगी वही बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहां तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में हमारी वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as Ashas or community level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते हो तो बाजार में जाने से क्लिनिक खुला है, वहाँ जाके चेकअप कराइए, सब करके बोलते हैं।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
मेरे को परेशान बहुत ये जितना मन सुस्ता, ये पैर मन सुस्ता था, ये पूरा शरीर का मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोल के, अभी तब से वो दवाई मन लेता, अभी तो रखी था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Bazaar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government's actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
Santa bastante depurali la cittadini ma scopo tanto da ni saban taro kader kite anche bastante tanta attivai
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव से आए सयान सदनमन आया दीदीमन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, समस्याओं का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें।
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है जिसमें हम लोग हाट बाजार में आते हैं जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते जो मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं तो गर्भवती महिलाएं आती हैं उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है अंदर रूम है वहाँ हम उनका पेट की जांच करते हैं जो इंटीरियर से गर्भवती महिला आती हैं उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिलती है
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Haat Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CHC रही वही बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहां तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में हमारी वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as Ashas, or community-level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते हो तो बाजार में जाने से क्लिनिक खुला है, वहाँ जाके चेकअप कराइए, सब करके बोलते हैं।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
मैं तो परेशान बहुत, ये जितना मन सुस्ता, ये पैर मन सुस्ता था, ये पूरा शरीर सब मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोल को, अभी तब से वो दवाई मन लेता, अभी थोड़ा ठीक था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Bazaar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health.
Thank you very much, Dr. Nima.
Good afternoon, and thank you for persevering with us for the final quarter of the global conference. This session, which is about global digital public goods for UHC, hopefully we'll be able to focus primarily around the core principles for the development of the digital health ecosystem, the incentivization and disincentives, and subsidies when it's required for DPGs, and also the governance issues. So I know that some of our speakers are keen to start. So may I, to begin with, ask Mr. Herko Koumans, if you would like, good morning, I guess, for you still. If you would like to kick off the session with your presentation. Herko is the International Digital Health Coordinator for the Ministry of Health, Welfare and Sport in the Netherlands, but he is much more than just that. He's been working quite a long time on information services maturity development for the local governments, web accessibility of government data, open data, change management, program management, as well as government information architecture and registries. The floor is yours, sir.
Good morning, or good afternoon, or wherever you are, and thank you for having us here. Like I said, my name is Herko Koumans. I work at the Dutch Ministry of Health. I'm also with the Global Digital Health Partnership, and I will be presenting to you the role of the Global Digital Health Partnership and what they can do with global digital public goods for health. So the Global Digital Health Partnership is a collaboration of 33 countries and national authorities on digital health, including the WHO, the OECD, and IDER. And it's a platform to engage those countries and those organizations in aligning their policies on digital health and to share their knowledge on and experience on those digital health policies, on cybersecurity, on interoperability, on AI, for instance, and other emerging topics. And in doing so, we help each other to advance digital health worldwide. So we facilitate policy and programmatic collaboration, and to accelerate the implementation and access and actions associated with digital health. So in that sense, we are very much like the work that you are doing, and we are adding to that. So who are part of this collaboration and this collective? I've added the country codes, but there's 33 countries, including India, including the Netherlands and the USA. USA is currently the chair of the Global Digital Health Partnership, and the Netherlands is vice chair. The previous chair was India, and this was a photo of the International Digital Health Symposium in New Delhi in 2019 with Mr. Agarwal, Lav Agarwal, as the chair. So that's India is very much involved, and the WHO as well. But I wanted to talk to you about a topic that is very dear to my heart and very close to the global digital public goods and also for health. A few years ago, I was at a presentation in the US from this man, which is John Cohn. He's an IEEE fellow at IBM, and he said something that is very resonant to what I believe, and that aligns with the values that are in the global public goods. He said that we are now at a crossroads. Either technology shapes society, or we say that society shapes technology. And what we want, of course, is that society shapes technology. And for that, it will help us shape technology to make us more human instead of less human. And to do that, he said, we are using standards. They are often very boring, but they are secretly exciting because they translate those values from society into the technical requirements so that we can help shape technology. And the global public goods, the public digital goods do exactly the same. So one of the main standards that I wanted to discuss with you, or which actually is not a recognized global public digital good yet, but could very well be a part of this discussion, is the International Patient Summary, the IPS. And I wanted to show you just a little bit what it is and where it came from and how it's different from other products and standards that are out there. But this is a truly global standard that can then be used in different ways across the globe. Oh, sorry. So the International Patient Summary is an extract of a health record, and it contains a collection of clinical information and some context information that a healthcare professional uses in their consult. It is the set of data that is used in as many generic ways as possible. So in care planning, or in an oncology visit, or in public health situations, this is the sort of core data set that everyone uses in their encounters. And because of that, it is actually very easy to use and to reuse in many different contexts. And it's called the International Patient Summary, which means that it's not just focused on a single encounter, but also on the bringing that context from one health system to another. And it's across boundaries. And we find that when countries are implementing this, or health systems are implementing this, that it's not just the international borders that these are crossing, but also their local boundaries or borders. For instance, in Canada, they use this for inter-provincial exchange. So this came about from a couple of European initiatives that led to a European patient summary that is being implemented in all the 27 EU member states now. And the Joint Initiative Council, which is the collaboration between the standards development organizations, the international standard development organizations, they said, we want to take this and to make this into a truly global standard, which is the IPS. And so this is not just one standard, it is a set of standards that all these different standardization organizations bring their, what we call artifacts, bring their content and services to, so that everyone can actually implement it across their whole health system. So this is based on ISO standards, with the European ISO variant is the CEN, which HL7, IHE, SNOMED, and the WHO is joining this as well. So it is a focused patient summary, so it doesn't contain all the information that everyone will need, but it is the minimal and the one that is mostly used. So it's generic, meaning that you can use it in many different contexts. So it doesn't limit itself to just one kind of consult. And it's also very much designed to be very simple. So it can be used across as many contexts as possible, and in as many places by as many types of people. So it could be patients themselves, it could be health systems, it could be governments, it could be healthcare professionals. So this is a very basic slide of what it contains. So there's information about what this message is, or this, if you get a summary, then you know where it's from, then you know who it's about. It's got a medication summary, it's got allergies and intolerances and problems list. There's all these. If you get a patient summary, an international patient summary message, then it will always contain these. Then there's recommendations on immunizations, which of course is very much linked to the public health use cases that we all very much have experienced. And there's optional chapters as well. And every chapter, all the definitions are standardized. So you know that if you get something for a plan of care, you know what it means and in what context it was created. Again, this is a collaboration and this is more technical. So ISO and CEN have published their information models. HL7 is publishing the implementation guide. IHE is has a IPS profile, which helps for implementation into healthcare IT systems. And SNOMED has published a free set for the global patient set, which includes then SNOMED is a terminology. So that's sort of the terms that you're using that are standardized as well. The thing here is that everything is open. It might not all be free because ISO and CEN have a publication model where you have to pay for access to that standard. SNOMED has a license model for member countries, but the global patient set that is used in the IPS is free for use. So this could constitute as a global public digital good. There's a resource on the IPS website where you can find a lot of information on how it is used and where it is used, including, like I said, information, for instance, on how Canada is using it and how we are using it in Europe. So the point here is that for global digital public goods for health and the role of this collaboration of these countries within the GDHP, I think that we can embrace this goal that the global digital public goods represent. And because it's kind of a big, huge goal, and that we can use this very important global standard of the International Patient Summary as a very good starting point that will help us to link all these different kinds of standards and global digital public goods that are being registered in the consortium for the global public goods, and that they can then be utilized for health, because we have sort of the basic generic standard out there that we can use to link all these other initiatives to, so it can be reused and strengthened, and the effects can then spread out more and more. If you want more information on the Global Digital Health Partnership, you can contact us and you can learn more on the website that is gdhp.health. And like I said, India has been a very strong and active participant and supporter of the Global Digital Health Partnership. We're working together in the G20 under the Indian chair. And of course, the WHO is very much an active member, especially on this part, actually on the IPS as well. So we very much appreciate that. Thank you. If there's any questions, I'm open to any comments.
Thank you, Herko. If you don't mind, are you going to be here until the end of the session? Because then I will postpone the questions, if there are any, to the later session. Let's continue now with the next presentation, which is with Prof. Alain Labrique. Alain is the director of the Department of Digital Health in WHO Geneva. But before that, he was also the founding director of the Johns Hopkins University mHealth Initiative and editor-in-chief for the Oxford Open Digital Health Journal. Alain, I'll ask you to start. Thank you.
So much.
Well, good afternoon. There's nothing more delightful than giving a talk at the postprandial slump when we've all had a good intake of that lovely food, and then I'll be the one trying to combat the instinctual drive that you have for sleep. So let's see if I can manage. So today I thought what I would do is talk a little bit more, zooming back out from what Herco presented to us about the IPS to the conversation around digital public goods writ large and how we feel that digital public goods can serve as an accelerant to national digital health transformation. And I think it's really one of the key linchpins for getting us to that end vision that many of the countries who have participated in this dialogue have defined. So there are a few definitions of digital public goods, and one of them is here from the Digital Public Goods Alliance that many of you may be familiar with. And it's really it's defined by them as open source software, open data, open AI models, open standards, and open content, which I think is a really important nuance that adhere to certain standards and best practices. They also have added a few value statements into this definition, including the fact that they do no harm by design and that they help attain health for all. So there's an objective to the digital public goods. Others, such as Digital Square, who we'll be hearing from later in this session, have also similar definitions, but again, focusing on the applications that are designed to mitigate some of the challenges of other open source software. And I think you can take a look at this list of criteria that are associated with digital goods, and you can see that they help to create a value system around what these goods are and how they are created and what they're intended to do. But I think I also want to challenge us to think a little bit about that word itself, the application. What does the application itself entail, right? When you think about the different layers of applications, I'm not a computer scientist. I sometimes play one on TV, but like many of us, we've been steeped in this space in digital health to be quite familiar with these components. And so we have the inherent logic that is within the application of the decision logic that dictates where, when you enter a piece of data, are you taken to next. The data model in terms of how the data is stored, and the user interface in terms of the experience of the user with the application. And then of course, there's the content, which is from WHO's perspective, asking whether that technical content is aligned with the subject matter expertise that the application is addressing. But I think what's important to consider for each of these four bins, logic, data model can both be standards-based. User interface can follow best practices in terms of capturing the end user, but also can emphasize accessibility, that is to say for literacy or disability. And the content can be validated in terms of whether it is evidence-based or not. But at WHO, when we think about reference applications, as Garrett pointed out in his lecture yesterday, we're looking at this idea of smart guidelines where we are trying to provide the global community with digitally ingestible content that includes the decision logic, that includes the data, the semantic and syntactic standards, as well as, in some instances, the generic white labeled reference app. That is to say, a piece of software that a country or a developer can take and adapt or adopt to the local environment to make sure that it is usable in that context. And so this particular reference app that I'm showing you today is one that is called MCare, focusing on WHO recommendations at the point of care for maternal and child health in emergency settings. And so you can see here articulated in the gray box, the kinds of interventions that are supported by the MCare reference application. And so why talk about white label software or standards-based certified content reference applications? Because one of the things that I think we've come to learn is that this makes the bar of entry, the point of engagement for developers, as low as possible when you're looking at a scenario where you're trying to bring countries up to speed across a wide range of technical content areas. And so that's what brings us to the WHO Digital Health Clearinghouse. And this is a mechanism that has been mentioned a few times this morning by our respected regional director, who talked about this clearinghouse that will assess and catalog digital health solutions in support of digital transformation, but serving as a repository for these white labeled reference applications that meet both the technical and the content standards required of a reference application. So within this clearinghouse, we have 5 different bars or benchmarks that have to be met in order for a reference application to exist within the clearinghouse. First, it has to fulfill both the functional and non-functional requirements for the reference apps in that particular health domain. It is required to be able to exchange data with other systems using open standards for interoperability. It uses health and data content that's consistent with WHO recommendations. It can address the implementation needs of low resource settings, which means what? It means it can be adaptable. It means it can be extensible. It means it can be scalable, no matter what the context in which these applications are being used. But also that they uphold the standards, as we've heard many times today, around data privacy, security, and patient safety. But I want to be a bit controversial and maybe provoke your thinking to say, is that all we mean when we say digital public goods? Or can we think beyond the application? Because as you remember yesterday, we shared with you this roadmap for transformation, and the application is just one part of the global resources that we would like to see countries have access to in their digital transformation